Oh, this is working. Okay, we went through the hearing test, little things. We went through the Hawkins-Kennedy test. Now we're at rotator cuff tendonitis. So we'll get to this in a couple of slides, but I'm telling you now, you absolutely must know the rotator cuff muscles. A lot of their kind of origin insertion, that's gonna give you some logic to lean on when you're trying to figure out pathology. You absolutely have to know rotator cuff stump, okay? It will be on your exam, it will be on your boards. Probably at some point, if you do an MSK practicum or OSCE, you will be expected to know this and demonstrate this. So this will live in your minds, hopefully rent-free for a while. So make sure this is a focus of what you take from MSK. All right, so rotator cuff tendonitis. So we're back to tendonitis, kind of the same run-of-the-mill tendonitis as we talked about in a broad term, but this affects one, some, or all of the rotator cuff tendon. Usually it's one or two. All right, so most tendonitis is kind of chronic. It's from, again, an overuse injury, a lot of overhead motions. Anybody have examples of this? Anybody have rotator cuff tendonitis? Yeah, what caused it? You remember?
There's actually, it's my first day, it's a tech, a
Ooh.
like patient
Okay,
got out of the road and like grabbed on. Repeating it so long.
cool, so yours was more acute, kind of trauma-induced localized inflammation, okay?
Yeah.
You've had more than just that. Live and learn. Anybody else have tendonitis? Okay, oh,
The whole class.
yeah. So car accidents, kind of mechanical restraints and all of that, yeah. That can let you do it.
Saw a lot of baseball players.
Oh, baseball players, anybody play baseball?
No.
No? None?
Nope.
One, dodgeball. Okay, so you still try. Now you have any injuries or?
Very similar. Dodgeball. Dodgeball.
Hey, there's a lot of crossover, yeah. Matt, you ever have any injuries playing baseball? No, lucky.
My like good friend was a pitcher junkie.
Oh, yeah. Baseball pitchers specifically, dodgeball, don't want to discount anyone. Throwing, overhead motion, okay. And then you have some people who talk about social history and occupation. Painters, people who are constantly reaching or repetitive motions, specifically overhead motions. You know, when you think about the anatomy, you're reducing the space to move the ball in the socket. So repetitive overhand motions can get you tendonitis. Usually that's supraspinatus tendon because of where it is. It can give you bursitis. Usually that goes hand in hand with kind of an impingement syndrome. All right, so you'll notice patients who have this, they'll complain of kind of shoulder pain. Well, the shoulder is 360. It's very global, so it can be hard to localize, shoulder pain. And that's where we go back to, can you point with one finger and show me where the worst of it is? Because they'd be like, yeah, it's here. And then like half their torso is involved. So if they're gonna point with one finger, it's gonna be mostly deltoid, so lateral shoulder, and then it will be worsened with overhead stuff, which could be something like I'm playing dodgeball, every time I play it hurts, or even just brushing their hair, washing their hair in the shower, trying to put a shirt on, things like that. So those daily activities will even be aggravated and difficult for them. Shoulders classically are worse at night. People say they can't sleep on that side. Now, one of the differentiating factors of tendonitis versus a true tendon tear is patients will have range of motion. So even after kind of these acute things, you could move your shoulder. It probably wouldn't feel great. You say, oh yeah, that's, causing me discomfort, but you can do it. When people have a rotator cuff tear, they physically just cannot do it. So you'll say, can you reach your arm up? And they'll try, and it just won't go. All right. So rotator cuff tendonitis is really a clinical diagnosis. You can do ultrasound just to try to look and evaluate the tendon. It's not done much. The only time we get an MRI is not to prove that it's tendonitis. It's mostly to prove that it's not a tear. All right, but usually with a good physical exam, you can figure out if it's weakness versus, true inability. All right, we treat this like most other things, especially all the tendonitis. Physical therapy for a long time sometimes. All right, anti-inflammatory, steroid injections, and avoid what is causing this. Now, as far as steroid injection, I talked the other day about utilizing that and kind of where we put that and where we don't. So we don't put it in and around the tendon. That's gonna put it at risk for rupturing. So we'll put that in the shoulder joint. All right, so it's gonna go in and around and kind of bathe all of those structures, the bursa, the tendon, kind of in that solution and calm it down, but it's not like I'm going in the shoulder and saying, oh, here's the tendon, let me put the injection right in the tendon or right where it meets the bone. That will put them at risk for tendon rupture, all right? As far as prognosis, usually this will respond to conservative treatment, but kind of keep in touch if their symptoms come back, always evaluate for a tear. As far as rotator cuff tears, I played softball in college. I was a pitcher. So this has been a long line. This ended up being kind of a chronic thing for me. I had a lot more than just rotator cuff surgery, but when you tear your rotator cuff, it can be from something more acute or it can be from something chronic. So you might get rotator cuff tendonitis and then it calms down and then it comes back and it calms down. And when you get that tendonitis, if it becomes chronic, you can get some calcification within the tendon. And it's truly that, it's calcium deposits, it's thick. And if you get an x-ray, it looks like bone, it shows up the same way. And that makes the tendon less stretchy, less pliable. And you know what tendonitis is, inflammation there. You can get these chronic micro tears and over time, you can just get predisposed to where it can tear. Sometimes for something good, sometimes not. And some people will fall, acutely rupture it. For me, it was dealing with this for a decade and pulling weeds in the garden one day, and the next day I woke up and just could not move my arm. So again, it sounds a lot like tendonitis, right? Deltoid pain, worse with overhead activities, night pain. Now, these patients, when you ask them to mobilize their arm, they just won't be able to do it because truly the tendon is not attached to the bone. So when you think of the pulley system, you know, squeeze the muscle, the tendon's attached to the bone, squeeze, you know, you get a lift. Without that pulley system attached, muscle squeezes, there's nothing that's going to happen. So you'll notice these patients, they'll have weakness, true weakness on exam, inability to do the performed activities you're asking them to do within mobility. So it's not limited from pain. It will probably be painful, but that's not why they're not doing it. It's not, oh, it hurts too much. It's just like, I can't. Patients will usually come to you with this. This was something I knew right away that it wasn't just a flare. It was, I literally couldn't move my arm. You have to get an MRI to confirm this diagnosis. So you can usually figure this out clinically, but you'll get an MRI to confirm it. And usually when there's a rotator cuff tear, they recommend repair. We do recommend, it's typically arthroscopic and it says plus or minus SAD. It's not because it's a sucky recovery. That's subacromial decompression. So if you remember that space, right, the more narrow that space is, they'll usually shave the bottom of that top bone, open up the space. That makes the repair easier in and of itself. And a lot of people with this problem have arthritis and bone spurs already there. Yeah, Jalen. Yes, subacromial decompression. So under the acromion, under that bone, they kind of just shave it, make it thinner. Decompress the space, make it bigger and wider. Now, as far as timing of this, that's not something I'm super worried about you knowing at the moment, but what I wrote here, the prognosis, it's good if the tear is not retracted. It is a long recovery either way. So if you think about that pulley system being disrupted, and that's happened for 6 months, you know, that muscle is still usually squeezing and trying to work, squeeze, squeeze, squeeze. It's pulling the tendon further away from where it really should be attached to the bone, kind of flapping in the wind. But if you let that go for 6 months, that muscle gets tight, the tendon kind of shrinks and gets smaller. It's hard to stretch and reattach. So usually when this happens, you want to reattach that tendon with the rotator cuff repair pretty quickly, or else it might not give you the same function, or it might be too late to kind of reattach it. So that's some background info. What I had here, I had 2 rotator cuff tears. I also had, we'll get into this, a labral tear. that they fixed. And I also had a chronic dislocating shoulder that they kind of tightened up my shoulder, if you will. So usually when you're going in for something like this, there's many other things they're fixing at the same time. Sometimes they'll do this and a biceps tenodesis because there's more strain on the bicep tendon that runs through the front of the shoulder if the rotator cuff isn't working. So you might have a rotator cuff repair with a biceps tenodesis or a biceps tendon repair. So usually if this is happening, there's kind of other stuff happening as well. What else? Sits muscles. Again, absolutely have to know this. These are the 4 rotator cuff muscles. We talked about this 1,000 years ago in AMS. So somewhere in the vault is information about this. Pull that right out. But supraspinatus, infraspinatus, teres minor, and subscapularis. So the supraspinatus is the most commonly torn. It's because of where it lives anatomically. All right, there's 2 tests we'll talk about where you can test the supraspinatus alone. So sometimes in your physical exam, you're trying to figure out, right? Is something torn? Is something inflamed? Is it a little bit of everything? These special tests will help you isolate each of the rotator cuff muscles independently. They tend to work together, but if you want to test if one's torn or not, you can isolate them. All right, that's pretty much it. We'll go through those special tests, but if you look and remember your anatomy for origin and insertion of these muscles, that will very logically tell you in what position, what muscle you're testing. So for supraspinatus, remember it starts on the superior posterior scapula and it goes right to the humeral head at the greater tubercle, if you saw in that other picture. The job of this when it's working is to abduct and flex. So forward flex, abduct the arm. So in order to test this, we do this Job test, which is named after a physician, or kind of empty the can test, which makes a lot more sense. But you'll have the patient stand up, abduct the arm, forward flex to 45, so front diagonal, then internal rotate, thumb should be down, and you want to see if the patient can keep their arm raised, then you want to push gently against them and see if they can keep it lifted. So when my supraspinatus was torn, I could not, I just couldn't. I was trying to do the test and I was using my trap to lift my arm, but it just would not go. So now works perfectly. In order to get a positive test, it's going to be that weakness. All right. So they just can't do it. So decreased strength, think neuro, right? Decreased strength, weakness may or may not have pain. So it's not pain that equals a positive test. It's truly the weakness, the inability to perform the action of motion you want them to do. All right, the other one that you can do when you think about the anatomy, again, abduction and flexion, you can have them sit or stand, abduct their extended arm to about 120. So here's 90, a little higher, 120. Ask them to hold the position and then slowly lower their arm. That will isolate a lot of strength of the supraspinatus. All right, so there's some deltoid strength that helps there, but if they can't do it, you'll see the positive test is they'll get to about here and then their arm will just fall and slap down against their side. All right, so they can't slowly control it all the way. Now for infraspinatus, so that's just below supraspinatus. It's the inferior posterior scapula to the humeral head. So same insertion, different origin. All right, that helps with external rotation. So keeping the elbow locked under the shoulder and moving the hand outward. And that's exactly how we test it. We keep the elbow under the shoulder, elbows flexed at 90, thumbs up. You got to keep the elbow still and see if they can externally rotate. If they can't mobilize their arm that way, or they try to lift the arm some, they're using the deltoid and maybe some supraspinatus to try to help. All right, so you got to keep the elbow locked under and open up. So you can do that without resistance. They may or may not be able to do it, and then against resistance. It's another reason why we're testing both sides. So test the right, test the left. In this picture, they're testing them at the same time, totally fine. And again, it's the weakness that makes a positive test, not just eliciting pain. All right, they may have pain, but that alone does not give you a positive test. Does that make sense how I wrote that? Okay. So teres minor, this is on the lateral scapula to the humeral head. Again, greater tubercle, same area of insertion. This also does some external rotation. This is not a commonly done test, but what you want to do is flex the elbow to 90, abduct to 90, externally rotate to 90. So here you're at that pitcher's position. Then you want to have them actively externally rotate even more. You only want to do light resistance there. And again, just to get to this position is going to be hard for someone with a teres minor tear. So that's enough. If someone also, like I did, had a chronically dislocating shoulder and you put their arm in this position and you press too hard, you'll just pop it out. So have to be careful thinking about beyond just one thing for shoulder pathology. And the last of the 6 muscles, your subscapularis. Now, this is the only one on the front, on the anterior portion of the scapula, and this goes to the lesser tubercle. So it's a little more rare to hear this, but patients who really struggle with this, it's pretty apparent. You know, if you want to test this, there's 2 ways to do it. You can have the patient sit or stand, you have their arm extended, and elbow flex, so it's kind of sitting on their lower back, their palm is facing out. And you want the patient to stay in this position and then just gently lift their arm off their back. All right, you can add a little resistance there, but most people, if you help them get their arm here and they have a subscap tear, they just won't be able. You see their elbow moving, but their hand will not actually lift off of their back. Can you imagine maybe what some of your patients, what they struggle to do if they have a subscapularis tear? Think female patients specifically. Very functional daily thing. Put on a bra. They'll come in and tell you, I can't get my bra on. Or I have to try to put it on like a t-shirt. You know, they really struggle with that kind of mobility of truly getting dressed, but they will always tell you in detail. It's just my bra I can't get on. I can figure out how to get into a shirt, get on a coat or a jacket, but that's what they'll come in and tell you. So that's usually indicative of at least a subscap tear. So the other way you can test this, you know, if you can't get the mobility even behind them to test it, you can also do the belly press test. So you can have them stand, you can have them do the sitting, but their palm will be facing them. You'll have them seated or standing, so their hands, shoulders going to be internally rotated, their palm flat, and you want to have them press against you. So your hand's going to be here, they're going to take their hand here. You want them to press against you as you push out. So positive test is if they move their elbow, but not their hand. So you want their position to remain this way. You don't want just their elbow moving. All right. So you got to think about, you know, is it just weakness? That's maybe not a tear. Sorry, that is a tear. If it's just pain, I don't know, maybe it's just a tendonitis or something else. So it's the weakness that we're looking for, the inability to perform the movement. All right, there's those 6 muscles for now. I know, there's a lot of tests. But you do want to know which one goes with which muscle and what makes positive tests. All right, moving on to labral tears. So I'll tell you there's generally a labrum in a ball and socket joint. So the big ones we'll talk about is shoulder, and then when we get to lower extremity, in the hip. So ball, socket, it's kind of this natural conformity, right? It looks like it belongs together as if you're putting together a puzzle piece. So that's great. The labrum is kind of this seal or this gasket that holds and seals the ball right in there. So from bony anatomy, it's meant to work, but that just seals it in, right? But you can tear this labrum. So this is like a fibrocartilage. It's different than articular cartilage. So this kind of feels like a meniscus. It's rubbery. It can be a little bit of a shock absorber. And again, this can be torn from repetitive overhead motion. So a lot of throwing athletes will get to dislocations, but if a shoulder has been dislocated, especially acutely, you probably have lost the seal and you've torn the labrum as well. So this goes hand in hand with some other injuries. These patients will have just pretty vague shoulder pain. A lot of time it's anterior shoulder pain, so they probably can't point with one finger. They'll say it's just kind of tight. The biggest thing they'll say is, you know, whatever they're used to doing, but they just can't really do it the same way. So, you know, oh, I play center field and I've always had, you know, a great arm, but now my arm's just kind of dead. Like it just doesn't work, doesn't go. Like it just, something's changed. They can't really tell you more specific details about that. Sometimes these patients will have clicking, touching, very mechanical symptoms. And then because this does seal the ball in the socket, this is frequently associated with either a dislocation or kind of subluxation, which is in a way a partial dislocation where the ball can slide a little more out of the socket, kind of quarter the way, and then kind of go back in. So they'll be able to describe that in vague terms for you. The way that we test for a labral tear, this is absolutely miserable. I don't know that this is done that much, but we flex the shoulder to 90, adduct, cross the body 20, internally rotate, thumb down, and then have the patient resist. So it's not empty the can, which is out diagonal 45. This is over and across. So we're really straining, and that's why for some of these tests, as you test sit muscles, if someone also has a labral tear, you can accidentally sublux or dislocate their shoulder. So within reason, all these things are done very gently at first. All right. Patients who've had a dislocation, they can feel when it's going to happen. They'll tell you, oh, I can't do that. My shoulder's about to come out, or it's moving, or it's sliding. But the other thing you can do is just see if they have some clicking or mechanical symptoms that are reproducible. Generally speaking, for this, we get an MRA, which is an MR angiogram. So what that is you inject dye into the shoulder, then put them through the MRI scanner. All right. Because the shoulder has this capsule around it, it should be sealed. If there's a labral tear and a problem with the seal, the dye gets out. If there's no labral tear, the dye stays in. So that's why we use dye looking for a labral tear specifically. You don't need it for rotator cuff tears. You need it for a labral tear. So sometimes, if you're looking for a couple different pathologies, what you can do functionally is put someone in the MRI scanner, evaluate their rotator cuff tendons, then inject dye and put them back in. Now that's no fun because MRIs take a while in their lab. You're kind of doing the same images, but that's one way that you can functionally look for both of these things. Probably won't see a labral tear very well defined without the dye. Probably won't see the rotator cuff tendons great with the dye in there. So sometimes you kind of do a hybrid. Now, sometimes for labral tear, we'll do conservative treatment. We'll say lay off the throwing sports, probably going to make this worse. If it's non-responsive to surgical or to conservative treatment, you can surgically repair this. I will say in clinical practice, usually if you're repairing this, it's because there's several other things going on. So I lived with a labral tear in my shoulder for 15 years and was able to just manage. Some things I just didn't do, some things I knew it irritated, but it really wasn't until I tore the rotator cuff tendons that I kind of had to have that surgically fixed, and they fixed the other things kind of as secondary. So the most common type of labral tear, we call these slap tears, which means superior labral, anterior to posterior. It's the method in which they tear and why. It's from that overhead throwing motion. So if you see a slap tear, it's just describing anatomically within the shoulder, kind of mostly around 12 o'clock back to 9 o'clock, where that tear is. All right, so it's nothing fancy. It's still a labral tear. Just sounds cool, maybe. And this is the type of labral tear I had throwing sports. I'm going to break it down in a slide or two from here. The other things you can kind of look for, labral tears being highly associated with dislocation. If you see a slap tear, you might also see or read on the report about a Bankart lesion. So that's what it really is. It's associated with a labral tear. So that's the take home of this slide. I'll show you what a true Bankart lesion looks like in a second. If you look closely at that top picture, see right where that biceps tendon inserts, right where the labrum is. You think about it anatomically. So again, sometimes we do a biceps tenodesis and a labral repair. So it's usually multiple things in the shoulder that when you're going in surgically, you're kind of gonna fix. When we talk about instability, this is usually more of something chronic that we're discussing. It can happen from an acute injury, and then this is the long-term result. Usually shoulder instability means several dislocations or chronic subluxation. So not just one side dislocated my shoulder in a car accident and it's been fine since. That's not instability. That's maybe you've had an acute dislocation and now your shoulders come out 2 or 3 more times, or it kind of slides around a little more than it should. You can test these things. The only one of those specific tests I'm worried about you knowing is the picture that I have there, sulcus sign. Be able to recognize that. I'm not worried about the other things, load and shift, apprehension. I'm not worried about you knowing those details. There's enough special tests. But you should recognize what a sulcus sign is and what that is associated with. And so that's the most common type of shoulder instability, this MDI, multi-directional instability. And what you'll notice is if you just have someone relax and you gently pull inferior, pull down, you can actually see anatomically the subluxation. And so you'll see kind of the sulcus sign, which is an area where you can just see the shoulder kind of gently pull away and sublux and pull just halfway out of the joint. And when you let go, kind of gravity and some of those other muscles are pulled together. So you grade instability like you would grade a tear or something else, right? 1 is mild, 3 is pretty severe. You do a lot of physical therapy and a lot of strengthening for this. The key is really a good home exercise program, a regular home exercise program to keep the other muscles around the shoulder strong. All right, so the stronger they are, the more their support the shoulder kind of staying in because they have better resting muscle tone. Now, if you end up going to surgery for something else, or you have chronic dislocations, they can fix this. What they'll do and what they did for me is they'll go in and, you know, the capsule is supposed to be like this and it's kind of stretched out. They'll use some kind of thermal stuff to shrink it down again, and then they'll tighten it up. So they'll fold it over itself and then tack it in with a bunch of anchors. So 5 anchors around my shoulder, kind of holding it a lot to anchor down, holding it in. But one of the things you can do if you guys do orthopedic surgery is sometimes you'll take these patients to the OR, and when they're under anesthesia, you can just very easily dislocate and relocate their shoulder because there's no resting muscle tone under anesthesia if they put in a parallel. And so you can grade their laxity that way. Truly, it's hard to do when someone's awake. Nobody likes to have their shoulder dislocated as a party trick. It can be done. I don't know if anybody else's shoulder dislocates, but wouldn't recommend. But under anesthesia, it's something you can do in grade, and that can firm up your surgical plan for what you're going to do. All right, so sulcus sign, associate that with shoulder instability, multi-directional instability. So here you are to true dislocations. You know, this is what I mean by this is the acute sense, right? Some traumatic dislocation. We talked about the, you know, kind of forced separation of 2 bones. And you can have an anterior or a posterior dislocation. And when you talk about dislocations, you want to think of where the distal bone is moving. That can get complicated as we get to elbows and wrists and fingers. How do you know if it's anterior or posterior, right? You're looking at the distal bone, which direction that has moved. So in this case, it's going to be, where's the humeral head? Is it anterior in front, or is it posterior, sitting in back of the bone? So to get an anterior dislocation, which is the most common, the arm's an abduction and external rotation. So maybe if you're reaching for something, this happens all the time in sports, someone comes and hits here, you can imagine this goes back, boom, the humeral head jumps to an anterior dislocation. It's sitting in front of the joint. So that's the most common thing because of the mechanism of injury, going back to why things matter. It can be very difficult on x-rays to figure out if it's an anterior or posterior dislocation. Usually you can see visibly with the shoulder. It can be very difficult in the hip. Sometimes you just don't know by x-ray. It's very difficult to tell. All right, so to get a posterior dislocation, the arm's got to be an adduction, flexion, and internal rotation. If this, if you take a direct hit or something, then boom, you can kind of jump this post, the shoulder goes back. That's a lot more rare. It's usually this one, so that anterior dislocation. Feel good about where the distal bone is going. In this case, it's the humeral head. These patients, especially the first time, this is acute, the first time dislocation, something like that, they're gonna have immediate pain. You'll see the deformity. They won't be able to move. Their muscles are all in spasm. The most important thing to do for any dislocation is do a good neurovascular exam. See if they have numbness, tingling sensation, and then vascular. Do they have distal pulses? Don't want to miss or let someone sit in an emergency room with a dislocation and have full arterial occlusion. If you wait too long, they will lose a limb. You have a case study on something. It wasn't one of my patients. I gotta find it. I have it. I'll share that with you. If you get an x-ray, you'll need several views for an x-ray to kind of see if it's anterior or posterior. The most difficult thing is it's hard to get your patients in a position for x-ray. They're in a lot of pain. They're in a lot of spasm. They won't be able to move the arm at all. So you have to get creative sometimes with what x-rays that you do. You do want to reduce this, recheck neurovascular status after reduction. You'll immobilize these patients, kind of let everything heal, calm down, and then send them to physical therapy for strengthening. NSAID's nice, always helps, but if this happens again and again and again, and once you've dislocated something and kind of stretched, it's more likely to happen and become chronic, which is where we get to the instability. All right, so two kinds of lesions, that Hill-Sachs deformity, which you can see on the top. Basically, with a traumatic dislocation, the humeral head kind of knocks against the glenoid, and that causes two issues. So you can see the impaction, kind of that dent right at the top of the humeral head. So even after reduction, if you see someone 5 years after this, you say, oh, did you ever dislocate your shoulder? You can tell because that dent is going to be there. A Bankart lesion is if you dislocate and there's a fracture of the glenoid rim. That's for anterior dislocations. That's one that you'll see somewhat frequently. You see a lot of ER patients. So you see that Bankart lesion is more inferior, and then a Hill-Sachs deformity is kind of right on top. Moving down the arm, as we get to humeral fractures, these are usually acute. In younger patients, it's from something like trauma. In older patients, remember what FUSH means? Fall on outstretched hand. Yep, it can be seemingly benign. Oh, I just tripped and fell, kind of, oh, but I landed on the couch. Or, it doesn't have to be this high impact in adults. Again, thinking osteoporosis, thinking high risk. So in older adults, their mechanism might not sound like trauma. It's usually a fall, but not the same kind of impact kind of someone younger would need to have a humeral fracture. All right, I'm not worried about the graph on the right. That is mostly to say it gets complicated quickly. All right, so this is more of a kind of ER thing, but I'm hitting on this because I have a case at the end about it. What you do want to do, which is very important, you do have to know, in a humeral head fracture, check the axillary nerve, right? How do you do that? You check lateral sensation over the deltoid and deltoid strength. A lot of times that's going to be abduction. So first 30 degrees of abduction. In a humeral shaft fracture, you need to check the radial nerve and make sure they don't have wrist drop. As far as pairing fractures, dislocations, and neurovascular exams, these are the things you have to know. Those will be questions, probably on your Clin Med exam, definitely on your board exam. Have to know that. Maybe on your ER exam, I don't know. All right, so to diagnose this, you get an X-ray. You really just need to see, and again, over on the right, these things can be disastrous. Where is it? Humeral head, humeral shaft. You know, based on all of those classifications, it's gonna depend how you treat it or fix it. Sometimes it's just a sling and gravity will kind of realign the bone and that's enough. Sometimes it's surgical. It depends on the chart on the right. That's the near classification system. I'm not worried about you knowing that system. It exists, it gets complicated quickly, plug and play, right? Thoracic outlet syndrome. This is a chronic problem. It's pretty rare, but it's a neurovascular problem. So the brachial plexus, neuro, and or the subclavian vessels get compressed. So that's through the thoracic outlet anatomically. Depending on what is being affected, patients will have neuro or vascular or neurovascular symptoms. Sometimes this is congenital when patients are born with an extra rib. A lot of times you'll see this from such hypertrophied muscles that there's true mechanical pressure on the thoracic outlet. So bodybuilders, kind of that classic look, those classic patients who might end up with thoracic outlet syndrome. Now, ironically, one of the physical therapists I worked with at the hospital, both of her children had this. Both of them had a congenital extra rib. Go figure. But they'll complain of some vague stuff, right? Upper extremity pain and swelling. They'll have some elements of vascular insufficiency, but they'll just say, you know, my arm gets tired so quickly. So almost like a claudication, a neurovascular claudication symptom. They might get the, you know, tingling and paresthesias. And this can be hard to find because that can also sound like something else. Does that sound like anything we talked about on Tuesday? Let me rephrase. It sounds like something else we talked about on Tuesday. Do you remember what that might be? What is it, Michelle? Cervical radiculopathy. It sounds kind of similar, right? Oh, upper extremity pain. I get some tingling and paresthesias. I kind of get weakness or fast fatigue. So it can sound like cervical radiculopathy. This is not the first thing people think of because it is pretty rare. So I wouldn't say congenital extra ribs are everywhere, but they're out there. So both of our children had to have surgery to take those out and decompress this thoracic outlet. I think one of the reasons they found it when both of them were like teens, early 20s, is they played lacrosse. And so a lot of that early fatigue and kind of really truly the arm symptoms as they were playing were something they complained about a lot. And she as a PT, you know, tried to do her evaluation, gave them programs and all this, and nothing was helping that because this is a mechanical compression. Okay. So they ended up having surgery. I think that's pretty rare. Normally, you can treat this conservatively once you're aware that it's happening, but this does sound a lot like cervical radiculopathy. All right, we'll go through the elbow. Olecranon bursitis. This can be acute, this can be infectious, or this can be chronic. That's when you get that big ball on the end of the elbow. It can be acute from a fall or a trauma. It can be infectious from a little cut, something gets in, staph usually causes an issue. It can be chronic, like George gets this from his RA. Also, the people who end up leaning, I'm not picking on anyone, so I do this, leaning on the desk,
No, I didn't.
right? You just lean and lean sometimes. All of a sudden, boom, and everybody's like, oh God, it's gonna be fine. Or crystallopathy, that can be a gout or a pseudo gout, can give kind of the same thing. That's more rare. But repetitive elbow trauma, that's the leaners, direct pressure. So if it's chronic, they'll have visible swelling. They will use that term boggy. Oh, my elbow's boggy. That should be associated mentally, RA, those boggy joints, right? It's kind of different reason, but feels and looks the same. It'll typically be red. Now, the chronic people, it's painless. They'll be able to move their elbow. Like when George gets this, it really doesn't bother him at all. It's more annoying, but it doesn't bother him. It's not painful. Now, if it's acute, something from a fall, then it's gonna be tender. And then it's gonna really bother them if you move the elbow around. So this is kind of weird because bursitis of the olecranon, it can be painful, it can be not. It can be chronic, it can be acute, it can be infectious. So you have to make your due diligence if you see this to make sure you put that in the right camp. What you don't want to miss is something that's septic. Now, sounds crazy that just a little bursitis here can make someone septically ill, fevers, chills, the whole thing. But it will be tender, it will be warm, they'll have limited range of motion. What we have to do for them is get rid of that infection. So you can aspirate. You'll see the kind of fluid that comes out. That's your first picture. Send that off to see. Is this from gout? Is this from staph? Is this fine, just acute? And we're not missing anything. So Staph aureus is the most common organism of a septic bursitis. That's the one you don't want to miss. Those people are usually systemically giving you symptoms, but not always. So most of the time, this is treated conservatively. Obviously, septic arthritis is one that we treat with antibiotics. It's very rare that we do something called a bursectomy, where you go and remove the bursa. You can do a bursectomy anywhere in the body. The problem is the bursa can regenerate. So it's like, will it come back? 50-50. It really depends how much it's bothering people. All right, you like charts, you like your recaps, there you go. Here's a picture, kind of an olecranon bursitis. So that could be acute, that could be septic, it's hard to know. Really have to feel it, have to talk to the patient. But visually, you know, because the red is spreading. When it's chronic, it's just the kind of ball there that's red. Doesn't really spread, but in trauma that can happen. That's probably something septic. You see the redness spreading around. All right. Let's take a break. I want fresh brains for when we go into epicondylitis. 840 tendinitis, 8 on where the tendons are located anatomically. So medial epicondylitis is the tendons that attach to the medial epicondyle. Everybody remember where their medial epicondyle is? Yes. Anatomic position first is this medial, lateral, medial epicondylitis. Okay. We call this golfer's elbow. It's also called pitcher's elbow. I have that in college. You have a lot of good fun sports, most of you know. This is, again, it's like any tendinitis, any itis, repetitive activity, overuse. Now, the thing to remember is these are where the flexor muscle tendons are. So if it's repetitive flexion, that, if you feel, you flex your wrist, you can feel the action there. If you feel on the lateral side, you're not going to feel the same. So even in your exam, if you start to get confused, just use you as a sample, okay? So medial epicondylitis, flexion, it's your flexor carpi radialis, your pronator teres. I'm not super worried about that. I'm not gonna ask you that. That's AMS stuff. We're all past that, thankfully, right? But patients will have pain and tenderness to palpation in the medial elbow over their flexor muscles and then tendon insertion. So because the muscles are here, they're probably going to have radiation into their forearm. There'll be radiation of pain, shouldn't be numbness or tingling or any of that. Then we go back to the cervical radiculopathy, right? But this should be more muscular radiation. So you can diagnose this clinically. They're going to have pain with resisted wrist flexion. All right, so when this happens, why it happens to golfers is, you know, they take their swing and as they follow through, they flex. I don't play golf, so I don't know if this is proper form or not, but they'll flex their wrist, right? Or when I was pitching, right? Flex your wrist, kind of your wrist snap or throwing, and you flex your wrist, and it's that repetitive motion that gives you golfer's elbow, medial epicondylitis. Okay. So of course, when this happens like any itis, try to avoid what's making it worse. Use a counterforce brace or brace or strap. Once it comes down, you can go to physical therapy and do strengthening exercises of the opposing muscle group. So extensor exercises to balance the muscle groups out in the forearm. You can do NSAIDs. If it's really bad, you can do a steroid injection. The same caution happens with, you don't put that right at the tendinous insertion because you can be worried about rupture. All right, so rarely you need to go into surgery or do anything more aggressive than conservative treatment. The other one is lateral epicondylitis. This is tennis elbow. So this is again, repetitive activity over use of the extensor tendons. So if you hold your hand out and you extend your wrist, once again, you should be able to feel that much more on the lateral side. So that's going to tell you already what's what. Just remember when you're doing this and thinking anatomic position, right? Like the man is always standing there like this, medial lateral, okay? Flexion extension, use yourself as a sample size. This will be the same thing, pain and tenderness in the lateral elbow and over the extensor muscles into the forearm. So you can do Cosen's test, which is in the bottom photo on the right, or Mills test, which is the photo in the bottom left. Essentially, you're kind of straining this area and see if it's reproducible for their symptoms. Once again, avoid the aggravating activities. You know, the reason this is tennis elbow is when patients are waiting to like hit a serve or a volley, you know, they take their hand back. It's this, you know, they'll extend the racket back before they go and hit. And allegedly, you're supposed to hit more with your elbow when you play tennis and not your wrist. Who plays tennis? No,
I'm sorry.
my culture mates play tennis. So she had this all the time as a pitcher. I always had medial epicondylitis. She had lateral epicondylitis. We were a pair. So with that, when we talk about counterforce braces, some of those straps, you see the strap there in the middle picture. Do you ever see people wearing those? Do you know how those work? It's really very simple. You change the mechanical stress. So right now, the mechanical stress transfers from the muscle all the way up to its insertion. But if you put a strap here and you change the pressure point, most of the stress ends up in the muscle belly under the strap. Less force is transferred through all the way to the epicondyle. So that's why those work. It's truly just changing the stress in the force. Now, I wouldn't recommend patients just throw on the strap and keep playing. You have to stop that overuse and chronic injury, chronic aggravation of that area, or it won't get better. Like most tendonitis, if this becomes chronic, you can get those calcifications there, and you can see that sometimes on an X-ray. Tendon rupture. So this can happen usually from chronic tendonitis.
Work really well.
It can be acute, but that's rare. It's mostly from chronic overuse. Again, when you see this, some of you were just asking about baseball pitchers. You hear the, you know, Tommy John surgery. They all need Tommy John surgery, UCL surgery. You know, they'll know right away. Not only will they feel, sometimes you can hear a pop, but usually it's going to be this medial elbow pain. That's that medial epicondylitis, the pitchers, the golfers' elbow. And it's because of the unnatural force and strain, that fast acceleration, the delivery, the force that goes through the elbow and specifically through that tendon. So you can actually test with a valgus stress test on the elbow to see if that tendon is still functioning and holding the bones together or not. You can confirm it with an MRI. Now, in the lay person, we might treat this conservatively and it might not be a big deal to them. But obviously all these pro athletes, they'll go on to have kind of Tommy John surgery and recovery. All right, before we move to fracture, there were some really good questions both Tuesday and today. So I haven't really gotten into PRP injections. Some of you familiar with PRP? Briar's champion PRP, bless you. PRP injections are platelet-rich plasma. So the way that we do PRP injections, you start an IV, take someone's blood, put it in a centrifuge, spin it down until you get all the best healing stuff out of that. You draw it up and you re-inject it into them, maybe at where they have tendonitis. where they have some type of injury. And the question is like, does that work?
Yes.
Typically, you'll hear everything. Yeah,
What?
it was a lifesaver or
Awesome.
it didn't happen.
Yeah.
And I think it probably depends, how it's used, where it's
some
used, you know, goodness,
Yeah.
should have brought extra. Plenty of. But it's probably better for more acute things. In chronic tendonitis, maybe. For a tendon rupture, probably not. That's a whole mechanical separation. For acute things, you know, the way that our wounds healing process works, the first phase is hemostasis. You know, there's blood that comes to the area, bringing all the good stuff to there to help healing. That's why, you know, that inflammatory phase of healing is, you know, redness, warmth, swelling, like all the good stuff is rushing to the area. PRP can accelerate, kind of help that process. Now, tendons don't have a great blood supply, so sometimes PRP can help that. And something like a labrum. The labrum is fibrocartilage. It doesn't have a great blood supply. That's why they don't heal on their own, like a muscle tear would. So if we put PRP in that area, may it help? Maybe. Will it? I don't know. But generally speaking, it's kind of this very gray zone, kind of like the chicken comb injections, that hyaluronic acid, kind of a gray zone. You know, we try to study this in a prospective and randomized way. And then we get level 1 data, and that's where the big people who sit on the orthopedic board say, this is what you should do for this. This is the treatment for this. This is the treatment, which is why we have everything here. Rest, NSAIDs, PT. That's all proven to help. It's proven to work. PRP doesn't kind of have that same data to be recommended. And for that reason, insurance doesn't want to pay for it because it's a procedure, it's expensive. So patients can pay for that out of pocket. Some people swear by it. Some of you know, you do it in your office, you see people get better and love it. My college roommate had this done. She felt for 3 days, she was in excruciating pain and couldn't move her arm at all. So you get kind of every end of the spectrum. So that's what PRP, platelet-rich plasma, is. You work in orthopedics, you're around it, you can see some of that. You know, for Tommy John, can it help them heal a torn tendon? No. May they have surgery and do PRP at the time of surgery? Maybe. So it's kind of this vague picture. I never had it done. At patients with osteoarthritis, wear and tear, missing cartilage, who some of them would, you know, ask Dr. Google who said to have it done, and they'd have it done, and then nothing. So it's probably going to be better in a sports injury, maybe more of an acute injury. A lot of pro athletes get it.
So for like visco supplementation, is usually, or it can be a series of injections. It's
Can be a series,
Is
yep.
this a series?
It can be.
Okay.
My college roommate had 3 injections done, I forget, it's been a while, a month apart. You know, some of the pro athletes get it once, they get it. So because it's all natural, it's you, there's not really a downside to it per se. So, you know, steroid, we're pretty strict. We only put that in about once every 3 to 4 months, probably have to be at least 90 days. With this, I don't know that there's real guidelines because there's no true formal recommendations. A lot of it is people saying, you know, in my clinical experience, this, or I tried that. When they kind of find something that works generally, that's what they go with. So they make their own protocols. Yeah, good question. Abel?
So is tendon rupture, is that only occurring on the medial tendons?
It's not only, but it's much, much, much more likely to happen there, your ulnar collateral ligament. So that's where when people say, oh, I ruptured a tendon in my elbow, 98% of the time, it's gonna be that. Yeah. If it's something truly acute, traumatic, something else can give, but when you see anatomically where that is, that takes the most strain from most of our normal movements. That's what it's gonna be. Yep. And when we talk about fractures, think about the bones that are there, right? Your elbow kind of joint, the 3 bones, your humerus, radius, and ulna. Usually this is from a fall or a direct blow. For some reason, this doesn't tend to be as much boost. This could be people falling backwards. So they'll have sudden and intense pain. One of my friends, her brother fell down the stairs, broke both elbows. Let me tell you, you can't wipe your butt when you've broken both of your elbows. His wife was pretty bummed about the whole thing.
Bummed.
Yeah, both elbows. So that was pretty interesting. He fell down the stairs. It's crazy
Thank you.
trauma,
She
right?
missed it,
But
that's okay.
with that, they'll have tenderness, they might have some numbness, when you think about the, innervation that goes through that area, there's not a lot of fat, there's not a lot of subcutaneous tissue to protect that area. So you have to worry about, again, neurovascular status. You can see this on an X-ray. And then the treatment's gonna depend on, can you cast it, can you splint it, or if it's displaced as this one is, do you need to have surgery? All right, specifically the one we worry a lot about is a radial head fracture. If you look at where the radial head is, it's right there on the joint, on that little ball. It's got its own little socket, if you will. This is usually a Fuchs injury. Will have the same symptoms everybody else does. Pain, swelling, can't move it as much, specifically with rotation. All right. When you get an X-ray, this you should know, you need to look for a sail sign. I'll show you what that means in a second. That's really called an anterior fat pad sign. And if you see that sail sign, you need to be very concerned about a radial head fracture. Why do we care so much about radial head fractures? Because it's usually an intra-articular fracture. So if you miss that, the way that it heals, patients will have chronically reduced mobility in their elbow, flexion, extension, supination, pronation. So they'll lose a lot of functional mobility. All right, so you look at the anatomy there, there's a lot going on. These are fixed surgically because even if they're 1 or 2 millimeters off, they want to line these up perfectly to maintain range of motion of the elbow. I have a picture at the end of what a true sail sign is. It's, which is bigger, but that middle picture there, anybody else today? There we go. So the sail sign, if you look at this as a boat, sailboat, see this here? This kind of extra dark area. I know it's tough to see. I would turn the lights off, but that's gonna start the light switch issue. But see how it's a little darker here? This front sail of the boat, the back sail of the boat. I know that there's a radial head fracture in this X-ray. I couldn't tell you where it is. Can't see the fracture line. But if you see the sail sign, that's as good to me as saying radial head fracture. Because of the swelling that's coming from an intra-articular fracture. Yeah, Michelle.
Can you get a sail sign with like a distal femur, a supracondylar?
It's a good question. I'd have to look that up.
Because I feel like when, like, in the office I worked at, when we would see it, like, we would see it in peds, when like, they had a supracondylar, but like, you can't really see it on X-ray, but if they saw a sail sign, they'd be like, okay, yeah, it's fractured.
Yeah, and usually, think about Salter-Harris and PEDS fractures, type 2, anything intra-articular is a concern.
Yeah.
That's gonna cause a sail sign. So, yep, good thought. So if you see that, you basically need to think something's broken. All right, even if you don't see bony fracture, that's concerning enough to say, you have to do more imaging, maybe we get a CT, or we're just gonna treat it as if it's broken. We really need to not miss that. Okay, your sail sign. We talk about dislocations. Remember, we classify these by bony direction. It's the distal bone. So if you look, the distal end of the humerus versus where the ulna is. Look at the distal bone and where that's sitting. That's how you classify. Is it an anterior or posterior dislocation? This gets hairy quickly. So look at the distal bone. Where's that sitting? That will tell you where your dislocation is. This will be pretty obvious. Again, any dislocation, you need to check neurovascular status at the time of the injury, when you're doing your workup, and after reduction, after you quote put it back. Hey, moving on to some other stuff. Vertical ganglion cyst. Synovial cyst. Anybody have these that you know? Yes. I have one, you have one? Yeah. Oh, TikTok is caught up with modern medicine. Yeah, so My phone's gonna hear you. Yeah, so dorsal ganglion cyst, so you see where that is, and it can come and go. You know, it's very benign. We don't know why this kind of happens sometimes. Sometimes it goes down on its own. You can't see it. Sometimes it pops up and it's very visible. Usually asymptomatic, people just don't like the looks of it or it's kind of annoying. If it's very close to a nerve, it can cause some of the neurologic stuff. But usually this is clinical. If you're gonna operate on it, you can get an MRI to see if it's wrapped around the nerve. That's more rare. But yes, the treatment for this classically is you take a Bible, because that's usually the biggest, thickest, heaviest book that people used to have in their homes. They'd say, okay, Minot, you have one of these? All right, put your hand out. Okay, let me take the Bible and you have to slam it. And you try to rupture the wall of the cyst. And that's fine to do because it's benign. There's just synovial fluid, it ruptures the cyst and maybe it goes away. So yes, TikTok is caught up with classic medicine. You can surgically take this out. You can aspirate the fluid. If you just aspirate the fluid, it will likely come back. This is connected to the joint, which is where the synovial fluid, that lining fluid of the joint, that lubricating fluid kind of escapes, forms a little pouch. So, yeah, thanks for sharing. TikTok's caught up. You what? Slam on their head. I've never slammed a Bible on anybody's head.
For any reason.
Contrary to TikTok's recommendations. No, I have aspirated some of these before. It comes out literally like a gel. The downside, and I've had mine aspirated before, it does hurt because you have to take a big 18 gauge needle to take the fluid out. Because it's like, you know, it would be like sucking down a really thick milkshake through like a coffee stirrer straw. You know, so you need a big needle, like you get boba tea, you know how big those straws are? That's what you need to get the fluid out of this. You need a big needle to get that really thick gel fluid out of the cyst. Get your books, yeah, get your Bibles, there you go, big books. So that's kind of the classic thing you'll see about dorsal ganglion cyst in the wrist. All right, de Quervain's tenosynovitis. So this is inflammation in the first dorsal compartment of the wrist, so right around the thumb. You can see on the top picture, right? So it's the tendon sheath. It's not the tendon itself. The tendon has a sheath around it. And going back to AMS, we're gonna keep moving past that. We can review some of that anatomy. But the tendon sheath gets inflamed. So it's gonna sound a lot like a tendonitis when your patient comes in complaining of it. But if we go to treat this, we're not injecting the tendon, we're injecting in the tendon sheath. All right. So it's the abductor pollicis longus, extensor pollicis brevis tendons, and it's overuse of the thumb and the wrist. It's also called mommy's wrist. Does anybody know why? What do you have, young kids? Why, Kara?
You have to hold babies.
They're holding the baby, but there's a lot of picking up, like,
Mhm.
oh, let me pick you up, and that is the aggravating motion. That's gonna inflame that first dorsal component.
Just want to say that.
So true, gender equality. Little representation.
A lot of times it is parents, it's loved ones, risk, yeah, but you had it, you have that, miserable, right?
Yeah.
Yeah. Yes.
Lay daddy.
Oh, the car seats, yeah, exactly, so. Right. Car seat, baby, you got a good bike of tendonitis, walking around the car seat like that, but yeah, this. Definitely, so that's gonna be your de Quervain's, named after that, tenosynovitis, so it, you know, all the things we talk about tendonitis, it probably feels like that, right? We give you all the symptoms, tendonitis. You know, patients can't tell you, oh, it's definitely, you know, it's the sheath around the tendon that's inflamed. No, you'll know that based on their clinical description of this. They'll have tenderness if you press on that, and you do the Finkelstein test, which I will not do on any of you. Maybe I'll do it on Nick because I think your wrists are fine. I'm not gonna make any assumptions, but you have them tuck their thumb in and then curl their other fingers around. You gently stabilize and you'll just gently kind of extend here. And if someone's got
You could have
tendinitis,
started screaming.
they will scream and pull their hand away just with the slightest mobility, by stretching it.
That
Be nice
hurts for
to
me.
her.
It's all the time.
Be nice to her. Yeah, it will hurt a lot. And they'll say,
No,
"Oh, it shoots right up my arm." So it's kind of following either the abductor pollicis longus or brevis. And that's
I'm
really how it's
diagnosing myself.
But no, it's will let
actually
you
have it, or
know.
Like,
That is
like it's not just
your
like sore.
kidney. So that's your Finkelstein
That's not feel
test, okay? Usually we treat this conservatively. One of the things you can do is put them in a brace. So this motion can't be happening chronically inflaming that. Because you can't tell your kid like, get on your own car seat, right?
I do that.
Tell to target. It doesn't work
But yeah,
like
it's a
that.
thing.
So, that's your Finkelstein test. Well, no.
I would be just like, I taught his son guitar.
And aren't they cool?
Yes.
He was like, he might have had ulterior motives, he wanted me to keep playing guitar.
Uh-huh.
He's like, look, you could wear these braids,
Like, it's
and
right
it might get better. You're gonna keep doing it,
Right,
or I can inject it.
right. You can, you're gonna keep picking up your kid. Yeah, definitely gonna be doing that. So when you do an injection for this, did it help?
It did, it was really painful.
It's pretty painful.
Yeah.
Yeah,
But it came back.
you can use a small needle for that, so that's nice.
It's really
Yeah, try to get
disorienting
it
to try to put it inside.
exactly, you're injecting this in an inflamed area, a small area. So it's uncomfortable, it hurts. And usually compound inflammation, but to that point, you keep picking up your kid, you keep doing that, usually it will come back. So that's where the brace can help, because it stops kind of that affecting motion. So it sounds, it looks, it feels like a tendonitis to patients.
Not
It's really a tenosynovitis, the lining, the sheath of the tendon is what's truly inflamed. All right. Next, we go to carpal tunnel. This is a common one. It's an entrapment of the median nerve. You have to know, it's the median nerve. Please don't forget that. The median nerve. Underline star. Yes, this will be a question. Have to know that. Entrapment of the median nerve within the carpal tunnel. So if you look anatomically at the top picture, you can see what is the carpal tunnel? Well, that's what it is. It's kind of this, the transverse carpal ligament runs across the anterior portion of the palm, and it's a lot of things kind of run right under that, including the median nerve. And when that tunnel gets smaller, the tendon gets, or the ligament gets thicker, that space gets tighter, there's irritation to the nerve underneath. So this can happen again, overuse. These are people, typers, like, I don't know, you guys have always had laptops, but in a desktop computer, they used to have those little wrist bumps. And you see the things for the mouse, with the little wrist bumps. That's all supposed to help against carpal tunnel, because it's the more flexion you have in the wrist, the tighter the tunnel gets. So it's repetitive wrist flexion. Some people get this from working in a factory, right? Repetitive motion. So asking about someone's social history, a typist, that used to be a whole profession, right? Just people who were typists. They would always end up with carpal tunnel. Obesity, pregnancy is another one. We haven't gotten to OB yet, but this is highly associated with pregnancy. Patients with arthritis, and then some of the endocrine disorders as well. But they'll get hand pain, paresthesia in the median nerve distribution, which is that purple area, right? Thumb first, second, and just part of the fourth finger. These patients, it's worst at night. Why is that? Shoulders are worse at night, we know that. Why, Chris? Yeah,
Sleep like that.
doesn't everybody sleep like this? Don't you all lay down and
Like a baby.
sometimes it's nice to feel snug in when it's cold, but you're like,
Really?
oh, I sleep
Like
like
with
this. Well, your natural kind of resting tone, your natural position of
Yeah, like
sleep,
this.
as you're literally unconscious, is
Like,
natural
like
wrist
this, like
flexion.
that.
So at night, you will go into natural wrist flexion, whether you need to or not. So these patients, they'll fall asleep, chronic wrist flexion overnight. They'll wake up and have to shake their hands out because they wake up with that nerve pain. Their paresthesias, numbness, they'll wake up and they'll say, "Oh, I have to wake up and shake my hands out to get feeling back in there. I wake up and it hurts so much." These patients also complain of some weakness. How would they, what are they gonna tell you? They can say, "Oh, Sydney, I have thumb weakness." Why is that? What are they gonna come and say in layman's terms in their history.
Started dropping things.
Started dropping things. I couldn't hold my coffee mug
Lazy.
anymore. I started
We're so
dropping
mean.
things because they're losing grip strength. So that's a secondary, problem.
Me
with
too, but I
carpal
don't
tunnel.
have any
And then you'll see
memories,
thenar
so I have no
atrophy, which
idea.
is this kind of bumpy muscle here. When that thins out, that's another sign of chronic carpal tunnel from compression. Again, you can put them in a splint, especially when they sleep. So the wrist will stay straight when they sleep in a splint and avoid the natural flexion. If they're doing repetitive motions, ergonomics are very important to what they're doing. And then you can do a steroid injection for this. Eventually you can have carpal tunnel release. It's pretty simple to do. They used to make like the tiniest incision. Now they can even do it arthroscopically, which takes longer. You do a good carpal tunnel release with a little mini open, 2 centimeter incision. It should take like 10 minutes. Very simple. As far as repetitive motion, George's daughter, who works in the OR with me, 2 things, opening all the sterile sets and trays. She used to have to
Say
pick them up because the way the sterile trays work, like this. So there's the sterile tray, and then there's kind of the inserts inside with handles. But the handles were very close to the outside part of the tray. So to open them, she'd have to tuck her fingers in here and lift. And with that, she got chronic tendonitis to the point where she couldn't stop, the equivalent of lifting her kid. She couldn't stop working and taking sterile trays out. So she had physical therapy, she had injections, she had a procedure where they kind of scrape, trying to induce some bleeding, the idea of a PRP around her elbow. One of them, she ended up having surgery to do a little bit of a tenotomy. She's also had carpal tunnel syndrome. So she's had both of her hands operated, not at the same time. Both of her carpal tunnel releases done. And it was her brother that broke both elbows falling downstairs. So we're just family. There's a lot going on. But this is pretty simple to do. It's pretty quick recovery. And there's 2 special tests that we can test for clinically for carpal tunnel. So again, you have to know median nerve, you have to know median nerve distribution. Palmar surface from the thumb, first 3 fingers, and part of the 4th finger. So Tennell's test, right? Tennell, T equals tapping. What you do, you literally just tap over, you guys learned this in foundations, right? Just tap over the median nerve again and again and see if it can reproduce the symptoms. All right, so positive test is reproduction of pins and needles right in that same distribution. Now Phelan sign, right? Phelan sounds like flex. So you flex the wrist to 90 degrees. It's kind of uncomfortable anyway. And then you hold it for a whole minute. You're looking to reproduce the symptoms in that same median nerve distribution. So however you remember them, that's how I remember them, right? So now it's the tapping, Phelan is the flex. So remember those, what they mean. There's my brain nuggets. Yep. Ulnar tunnel syndrome. This is a little more rare. But again, around the elbow, there's not a lot of room for neurovascular structures and all of, adipose or subcutaneous tissue. So the ulnar nerve that runs through there can get trapped, if you will. This can be from trauma. Usually it's from repetitive activities or something there like a cyst, something anatomically they're taking up space that shouldn't be. And they'll get essentially, quote, carpal tunnel syndrome symptoms, but in the ulnar nerve distribution. So it's the other half of the 4th digit and the 5th finger. Now, the neurovascular symptoms that can happen is it can actually give them like this claw hand because the muscle can go into spasm. It can be affected. So if you do Tennell at the elbow and you tap, you can get that ulnar nerve reproduction. You can also flex the elbows like that for 60 seconds, a whole minute, and see if that happens. So ulnar tunnel syndrome happens at the elbow. It's kind of like carpal tunnel in the elbow, right? So it will sound the same. It's just you have to use, your anatomic landmarks to figure out which nerve is affected and then do your test. Usually for this, they'll look with an EMG, which we talked about a little bit the other day. A lot of conservative treatments are the same thing. It's very rare to do a surgical decompression. But again, when you sleep, naturally the flexion, so these patients will also have symptoms that are worse than night. All right, moving down to gamekeeper's thumb. It's also called Spear's thumb. This is if you fall and typically injure your ulnar collateral ligament. Which, we back up a second. Didn't we talk about ulnar collateral ligaments? No? No? We did it?
In rough average.
Oh, ulnar collateral ligament. There it is. And what are we talking about now? Ulnar collateral ligament. I don't know who names this, but you have another ulnar collateral ligament. So keep that in mind. It's one in the elbow, also one in the thumb. Okay? These patients, it's a ligament tear. It's gonna act like any other ligament tear. Pain, swelling, limited range of motion. Again, they're gonna have difficulty pinching, grasping. If you stress that ligament, you'll notice they have hypermobility on one side, especially compared to the other. So you want to make sure there's no fracture. As we get into wrists, that's something you don't want to miss. You're going to x-ray a lot of wrists, making sure there's no fracture. You really could get an MRI. The MRI is to look at the ligament itself. Typically, this is treated with a thumb spica splint. And so as far as skier's thumb, you know, you have the ski poles, people are skiing and then they fall. Oh, and they fall on the ski pole. So, you know, typically your hand would hit the ground, but if the ski pole is there, that hits, this surface of your hand hits and the thumb goes and it pulls it out and that's where you get the tear. So that's why it's skier's thumb. Any idea why it's gamekeeper's thumb?
Let's do.
What is it? Gamekeeper. What's a gamekeeper?
It's a bird. Isn't a goalie?
Why, Liza?
Is it from the, like, the gun taken back?
It is, it's something with hunting.
Mhm.
It's breaking the neck of the bird.
Ah, breaking the neck of the bird. Got it. So this was, again, this came from like the Bible blasting, right? Like we're talking about the same time when we start naming. But yeah, people go out
Bible.
and they, from the geese, usually they go
Yeah,
and
put your
they
hand on the table.
break the neck of the geese,
Just look
holding
for a
it
second
and
here.
using their thumb. And that
Take
counterforce
like the
resistance
chiropractors.
over time would slowly
Just 1 second.
lax out, stretch out that ligament. So you have hypermobile. And then chronic, you know, ligamentous stretching and then tearing, so gamekeeper's thumb. A little nicer to think of skier's thumbs, but you'll see both. Classic name. No, not video games. You probably get CMC arthritis from video games. This again, you can treat it conservatively. I did this in college. I did not break any instruments, no. Actually, where I went to college is really interesting. A lot of my teammates would hunt, and they all went out like clay shooting. And they were like, "Do you want to shoot this gun?" And it was like this. I've never shot a gun, so this was a little bit of culture shock. Anyway, it's huge. I guess it's a rifle. And I watched the first one kind of shoot this shotgun or whatever, which had a crazy kickback. And then I realized the butt of the gun sits right here. I am right-handed. I realized very quickly, if I shoot that gun, it's gonna dislocate my shoulder, no thank you. I did not just sat around and drank what I drank and called it a day. I never shot anything, I never did any gamekeeper thumb injury from goosenecks, but I was going to conditioning one morning, it's very cold, there was a lot of snow. And there was so much snow, I'm talking like 2 feet of snow, you can't really see where the steps start. And so I thought I was about to go down the first step. And I was wrong. I had already gone down the first step. And so I started sliding. When I went to catch myself, I happened to catch like the side of the railing and it, yeah. And so I had gamekeeper's thumb, which you'll find. I also tore a piece of fascia in my thumb. So comparing right to left, different. Yeah, that's a weird injury. Different. I'll tell you what you can't do with gamekeeper's thumb. You can't swing a bat. Because as the fall through the back, it also starts to form the thumb. So anyway, little things. Luckily, I could drink coffee right-handed, not a big deal, but little things. So they can happen outside of ski and goosenecks, but that's kind of what we call it. So I was in a spider splint for a while. Still up fine. Talk about wrist sprain. So this is a little complicated, so I know we talked about sprains and strains and all of that. This is a wrist sprain, if you will. The most common way to kind of sprain your wrist is to stretch your TFCC. Fancy thing called your triangular fibrocartilage complex. Kind of netting of fibrocartilage, and it holds the scapholunate bones together. So there's 8 carpal bones. The one we always care about the most is on the next slide, the scaphoid. Don't want to forget about that guy, but these two. So you see right there, right above the radius, see how far apart they are? That's too far. And this is when you look at normal x-rays over and over and over, you look at that and say, okay, nothing's broken, but those bones are too far apart because the soft tissue between them is stretched. So usually this is twisting or falling. Patients have ulnar-sided pain, weakness, limited mobility, sometimes a clicking and popping. I also did this injury with that weird fall thing. Again, we x-ray a lot of wrist. You don't want to miss an x-ray. Then if it's something soft tissue, you can go to an MRI for confirmation. This is really difficult to treat. There's not a lot you can do. Wrist splints, conservative treatment. Some maybe PRP, I don't know. But there's not really a great surgical fix or repair for this. So you try to treat it conservatively, immobilize it, see if it'll kind of scar in and hold up. The biggest thing with any wrist sprain is this is what you don't want to miss, right? You don't want to miss a scaphoid fracture. So again, Bouche injury will have the pain and tenderness in the anatomic snuff box, which you see there. Does anybody have a good snuff box? Maybe?
Oh, yours is
Remember?
really good. Yeah.
The
Been
Bible beater time, do you remember what that was for?
Yeah.
How was it? Okay, put your little head in there and right out. You need the table and a rolled up paper. That's all you need. Your little anatomic stuff. So now, that's now where we're not throwing cocaine at it, but we are as clinicians pushing on it. And
You know,
if
it's
there's any
funny.
Push there, it is a scaphoid fracture until proven otherwise. So you might get an x-ray. You might talk to the patient, what happened? Oh, I fell, it hurts, blah, blah, okay. You do your good history. You do your good physical exam. That's right in the anatomic snuff box and they jump. Oh yeah, it really hurts. That's tender. Feel that. All right, let's get an x-ray. Get an x-ray, you look, you're in an ER, the radiologist will look and say, no, no fracture. Then you go back to the patient, you push on that spot again. Oh yeah, that hurts. Do not miss it. This is very easy to miss. Even if the x-ray is negative, if you have a high index of suspicion, which is tenderness there, you probably need a CT scan. Right, CT is really good at catching occult fractures, things that are hard to find. This is the one you don't want to miss. Now, if it's something occult, you'll probably put them in a thumb spica splint. Sometimes they'll need surgical intervention. The biggest thing is you don't want to miss this because of AVN. Remember what that is? Avascular necrosis. Yeah, so the way the blood supply goes into that bone is almost like a little backwards. So if you cut off the blood supply right in the middle of that bone, there's no collateral supply to the other side. So avascular, no blood, necrosis, that bone will die. And once that process happens, it is too late. So that's what you do not want to miss. But yeah, TFCC, skier stuff and all that, yeah, that's fine. This is what you don't want to miss. You need to be able to pick out which bone that is on a radiograph. I suspect you already know how to do that. Maybe you need to remember from diagnostics how to do that. Which bone that is, which one to look at, all those carpal bones. All right, going down the hand. Couple more, then we'll take a break. So OA, osteoarthritis of the CMC joint, carpal metacarpal, that's the base of the thumb. If you look at the positive red arrow sign on the top right, that's your carpal bone, metacarpal, base of the thumb. It's a very, very, very common place to have arthritis. So people will say, I have pain at the base of my thumb, I can't pinch, grasp. They're also dropping things like their coffee mugs, right? They might have catching, clicking, or grinding. It's truly because the cartilage is gone. The bone is literally grinding together. And that's what you can do. Like you see in that picture, you can stabilize the hand, grab the metacarpal, push it down into that joint, and roll it around kind of in a rotational area. And you can hear or definitely feel grinding. So grinding like a peppermint. So positive CMC grind test. Because they have arthritis right there in the thumb. Very, very common. I'm being dramatic at the end of surgery. And they've given me pickups I don't want to use. I say, no, give me the other ones. I already have CMC joint arthritis. And then they roll their eyes and give me one else. Using your tools in the OR pickups constantly using that, so. Treat this conservatively, like all other osteoarthritis. There is surgical options now. It's not a true joint replacement like metal plastic. You can fuse those bones together, you'll lose mobility. But you can also kind of take a tendon and wrap it in there as if it were some cartilage, and they're getting there with that. That's a long recovery, but had one of our family friends do that. She loves it. All right, the next two, make sure we can compare contrast them. So Dupuytren's contracture. This is a fascial thickening that causes the fingers to flex towards the palm. So the fascia is that very thin lining over muscle. You have that all over the palmar surface. This one was torn. This is not a Dupuytren's contracture, truly. This was torn and it just started in its height. But that's where your fascia is, through the palmar surface. So a true contracture is fascia thickens and it chronically contracts. So it's a kind of slow progression at your metacarpal phalangeal joint. And then you get these very visible and palpable cords. You get this chronic contraction. It's usually in the ring finger where it's just kind of stuck like that. The clinical diagnosis, you can do some physical therapy, try enzymes to kind of dissolve that thickened fascia, that scar under there. You can have surgical resection or fasciectomy, kind of cut that and increase mobility again. All right, that is different than a flexor tenosynovitis. In our back, tenosynovitis. So this is, again, the lining, kind of the synovial, the lining, the sheath around that area. We call this trigger finger. So this is the flexor tendons, which are also on the palmar surface of your hand. And it's this kind of A1 pulley. There's a ton of pulley systems through your hand. I will not bore you with them. This is the A1 pulley where the flexor tendon, the tendon itself gets thickened from kind of a chronic sheath inflammation, a chronic tenosynovitis. So tenosynovitis, like the mommy daddy wrist, this is kind of the same thing in the palmar surface. It forms this nodule that's a little bit painful. And you get this catching or triggering with flexion. So if you look at the picture on the right, see the nodule that's on the tendon itself. What it can't do is slide through the pulley system. When you think carpal tunnel, kind of that sheath on top, we have the same thing in our fingers. That nodule can slide maybe under, or kind of slide back, but it won't slide under. So it kind of gets stuck. So mechanically, finger can go one way, but then you have to like open it the other way. So it's a clinical diagnosis. It's very common. Usually we treat this with cortisone to reduce inflammation, hopefully let that slide a little faster, a little easier. You can splint this, do some therapy, but surgery is pretty common. This is also a very thing. It's almost like carpal tunnel. You open little tunnel that pulley has to go through. You leave the nodule there, you just open the doors so the nodule can keep moving. doesn't get stuck. Yes, Ryan. Always a chance. You want to have show and tell later? Ryan had show and tell on Tuesday. But this trigger for you. Yeah. Very cool. Which finger is it? Fourth? Ah, all right. Well, you don't fit the mold exactly. It's more common in your ring finger, but that's okay. I'll accept, and your middle finger. Okay, I was wrong. So there you go. You can use that as a subtle excuse when you're really feeling upset, but your finger was stuck one way or the other. Don't get stuck down, not us. Sorry. As far as fractures, this one you probably heard before, right? Kind of wrist fracture. This isn't really a wrist fracture, it's really a hand fracture. But this boxer's fracture, this punching mechanism, this trauma, it's a fifth metacarpal shaft fracture, but it's distal, it's close to the knuckle. These are people with localized swelling, pain, and tenderness. They won't be able to mobilize their hand that much. Their knuckle will kind of just disappear. So, you know, when you flex, you can see and cut your knuckles. See how many days in the month, each month passed, whatever you use those knuckles for. But you'll be able to count on that one, because it'll disappear. You can find this pretty easily on an X-ray. Probably want to put this in an ulnar gutter splint, or cast it. If it's not displaced, if it is displaced or kind of angles, rotates like the one in that picture at the top, then it's going to need a surgical intervention. So it is interesting to work in the emergency room. Remember, a guy came in with this injury and his X-ray looked almost exactly like that. He said, mechanism injury, what happened? Oh, I was, what was it? It was something where his wife's girlfriend's hair dryer was plugged in the bathroom and he tripped over the cord and fell. That had this X-ray. I can tell you that's not what happened.
You tell him that.
Yeah.
It didn't matter if I told him that I knew what happened or not. This is when I was a student, but we all knew that wasn't really what happened. And then you have to start thinking socially. Is he hitting people? Is he hitting a wall? Anger management, you know, there's a lot more that can go into it, especially, you know, college. It's always college boys. Two of my friends have had this fracture from punching walls. One was like a cinder block wall. Anyway, they went to WVU.
Idiots.
Other
That
than
explains a lot of things.
Mountaineers,
Mountaineers, baby.
Drunk idiots and punching.
It's not like the highest
Okay,
dropout rate.
Yeah.
They'll tell the story. It's not a secret, right? Like,
I
you know.
literally know.
But when someone comes
So do
in,
I.
it's extremely
Yeah.
story and it's
I
not-
became a
not
Mercedes sales guy. I
And
think he's
maybe
doing well
there
now.
should be another
Oh,
component
she's
that
married. I
you
don't
think
know.
about when this shows up. But if you look at the picture, you know, when you close your finger,
He
look
used to
at
hook up
the
with
go
him.
straight down.
He's like,
If
cool
you
way.
look at the bottom
Like,
right,
teach you how to
you
drive
can see the one with the
shift.
boxer
Real quick,
fracture
I was
that's
like,
kind of
okay.
angulated.
He was like, so you can give me head?
It twists and the pinky kind of falls over because that metacarpal is
Right outside my driveway.
Then he wanted to admit to the boxer fracture from punching wall and driving. Yes. Kevin?
So, so it's just funny because I got a boxer fracture from playing basketball and my feet were cut off under me.
Ah.
I came down and I essentially punched the
Punch
ground,
rounds, yeah.
but the trainer who saw me, because it was in high school, the trainer who saw me accused me of lying. He was
Mhm.
like, who'd you hit?
Yeah,
Who'd you hit?
I think too. I'm a lover, not a hitter. Yeah, I think there was
Rather
something
be a
else with
lover
this
than
guy,
a
like,
fighter.
well, you know, how did you land? And he said, oh, I really, you know, land like a natural boost, you land that way. So you know, you can piece together, sometimes pictures will tell you mechanism of injury versus, you know, patient's not gonna tell you.
You know what this
So these
is?
three things you have,
Bones.
but yeah, you're gonna, it's gonna be a lot of impact with a close.
Your favorite. Just
There we
different
go. Now,
podcast.
true boxers, right, they're hitting all the time. They know how to kind of punch correctly and
Yeah,
not
with
lead
the
with the knuckles, so they don't end up with stuff like this. So, yes, a professional hitter will not end up with this. Other fractures, parts of the finger, these are tuft fractures are the ones, it's the very distal portion of the distal phalanx. The thing you have to know is there nail bed involvement? So that's something always to remember, is this an open fracture or not? But usually it's a trauma, a crush injury. People, this is gonna make you cringe, closing their fingers in the car doors. Yeah, that's usually this, the tuft fracture. So it's usually associated with an open wound as well, a true cut and a distal phalanx fracture. So you're more worried about the open wound, the infection and stuff like that. Also with this, it really depends, your little flexor extender tendons that are there, they get disrupted. So a lot of times you can pin these and hope that everything scars in and you keep all mobility of every joint in your finger. So you can do this non-op with a splint. Always give antibiotics for an open fracture. And then with the nail bed, look for infection. If there's a subungual hematoma, you can press that. You can pin this. All right. So as you go through clinical pearls, there's one in here that doesn't apply to you, but most important piece of history is the mechanism of injury. Remember, Salter-Harris is something we use for peds, really. But we're talking about a lot of infection and septic bursitis. It's going to be staph. You know the difference, strain and sprain. I don't really care that you know cervical whiplash is coup contra coup. Probably emergency medicine, you might want to know that. I'm not going to ask you about that in Clin Med. We hid that slide on purpose. All right, you do need to know some of these things like Sperling test, the cervical radiculopathy, extension and turn towards the affected side, right? Gentle axial load. How to know those sits muscles. Probably know anterior shoulders are anterior shoulder dislocation is most common because of the mechanism of injury. Know the difference in the epicondylitis, flexion extension, unilateral. Know about sale sign, carpal tunnel stuff, gamekeeper's thumb, UCL, same as you need Tommy John surgery, UCL. All right, boxer's fracture and then trigger finger. So let's practice. Before we practice, think very carefully for the first slide I gave to you on Tuesday. The pet peeve slide. Remember that one? Okay. Channeling that. And where we're going to start. What type of fracture is this? A right. There's the fracture. You can't see. Again, I'm not gonna turn out the lights, light switch issue. Yeah. So a right, and let's try to use anatomic. It is a boxer's fracture, correct? How else would you describe that? What bone is affected? Fifth metatarsal, metacarpal. Sorry. Yes. It is distal, fifth metacarpal. Good. When we look at classifications, right? Which direction is that bone broken in? I heard it, transverse. Oh, I gave away the answers too soon. Transverse, it's also, this is non-displaced, there's a slight angulation. That I don't really care that you know, but I just want you to start wrapping your mind around some images like this. We just said mechanism of injury, boxer's fracture, punching injury, and then the splint, ulnar gutter. Do you remember what that looks like? Looks like that. Okay. Got it. Right. There's more. Uh-oh. Okay, let's think about this. What type of fracture is this? Where's the fracture? Do you see it?
Scaphoid.
You see the fracture? There we go. Okay. What kind of
The left
fracture is
side,
this?
yeah. Left scaphoid fracture.
Hard to tell.
Hard to tell. It really depends. One, x-ray, I would never give you an x-ray like this and expect you to tell me. You don't know if it's this, whatever. It will be labeled or much more obvious. All right, so don't panic. You're looking like, I don't know. If you don't know, use your best judgment and write something, right or left. Say it's right or left, I don't know. Fine. Choose something. Which bone? Scaphoid. What direction is the fracture line? What kind of fracture? Transverse. How else would we describe this? Non-displaced. All right. What mechanism of injury? Probably a poosh, yeah. And then what's splint? Spica, love it. I wrote right, I don't know why I wrote that. Either the place I pulled this from said it was a right, I have no idea. That's not the take home, you need to tell me something. Good? Got it? Okay. Here we go. Do you see the fracture? Okay, what type of fracture is it?
Radial head left. No.
It's left, this is a left. And what else was it, did you call it?
One or two rows.
Radial head, is it radial head?
No.
Definitely the radius, but is it the radial head? No, that's a kind of quote elbow. Okay, so how would we describe this portion of the radius?
Two rows.
Distal radius. Yep, so there's your fracture, right? Right, distal radius. What injury do you suspect? Push, fall. What splint? You know, you can call someone else, to figure it out. All worth it. Any other thoughts? Oh. Oh no, she tricked us. It's a left distal radius and ulnar styloid fracture. So this is the tricky thing with reading x-rays. Make your systematic approach, right? It's very easy to see that big one right in front and then poof, your brain goes black. It's kind of like reading chest x-rays, right? There can be more than one thing happening, specifically.
Two arrows on our
with
slab. We just like
musculoskeletal.
missed that.
So this
entirely.
is, yes.
See what I mean?
It's a distal radius fracture. It's also impacted.
Yeah.
So it's kind of a, almost like crushed together. You can see the overlying cortical bone that's kind of crushed down. You always need, really, you need a lateral to see if there's an angle or not to this. And then the ulnar styloid is probably an avulsion fracture. Fish injury, I agree with. Does anybody remember the splint? Ooh, sugar tongue, love it.
She gets one.
So there's your injury. Here's your splint.
She gets one.
Right? Uh-oh. What kind of fracture is that? Make up a side. You should really be able to, I mean, I should be able to tell. I don't even know that I would. Do you see the fracture?
I'm gonna fuck
Yeah, you see that there. Okay.
Why does it look so green?
Any idea how much side it is?
Because it's the one behind it. Oh. I was like, why can't I see it?
What side? Yeah, you're right. Left.
Oh, I couldn't.
These are tricky because I don't know. You know, what lateral or what approach they took, probably, you know, to get that elbow without anything in the back, you know, how did they get that x-ray? And with fractures, sometimes it's hard. That's why they have to label them. Yep, a left proximal ulnar fracture, right? So ulnar fracture, proximal. What kind of fracture? How would you describe this? Is this transverse? Hint, it's not. Any other thoughts, words? Oblique? I think so. Oblique, what other words? What is it?
Specifically, like,
Specifically, yes. And what are you getting at? You're naming the parts of the bone. Great. Yes, this is how we get there. So an oblique fracture through your olecranon. And through the joint. This is, yes, an oblique intra-articular fracture. So you're looking at kind of the area of the bone and then see how it goes all the way through the joint here. A bad problem. Any idea how this happened? Oh, okay. Erin has a question. Let's pause. Question, answer. Hopefully.
Going back to the, caption.
Yes.
Why don't you?
With this one?
Yeah.
There is slight mobility between the radius and ulna when you supinate from them. So a lot of that is coming from the elbow truly, but when you have kind of dual fractures, you also don't want that happening because there's mobility there. You might have some secondary soft tissue damage, but if both of those are broken, we typically will not want supination for that reason. Good question. All right. Left proximal ulnar fracture, oblique, intra-articular. Any idea how this happened? Yeah, Cindy, how would you describe that? You're really excited.
Could be a fall.
A
Yeah.
fall, but in this exact position. So a Fuchs injury isn't gonna end up like that. You're gonna fall on a flexed elbow. Or punch the ground. You're gonna punch the ground with your elbow. So it's kind of a unique injury. You can do this on both arms by falling down the stairs. Yes, George's son knows. Yes, a really strange mechanism of injury. This does kind of make sense, right? And then you put a long arm posterior split on this. Okay. Number sale sign? Anybody look for that? Or did you see the fracture? That really excited me so. Yeah, there's no sale sign on that X-ray. But what does this indicate? What kind of fracture? Radial head. Radial head. Okay. What type of fracture is this? Okay, let's use the X-ray. Right. That one's labeled. A right. What bone? Humerus. What part of the humerus? Head. Okay, right humeral head fracture. Is it just the head? Look at that lateral. Is any other part of the bone? Yes, it's through the neck as well. Okay. What kind of fracture? How would you describe it? It's not transverse. What is it? Well, someone said it. Comminuted? Yeah, it's a mess. It's in 1,000 pieces. It's a comminuted fracture. How do you think this happened? This is one of my friends. How do you think this happened? Not the ones who went to WVU. But it was a fun one. No, he wasn't playing sports.
Jumping.
He was not in a fight with anyone else. Let's say this happened at 3 o'clock in the morning.
Brandon
Fell down the stairs.
He fell down the stairs.
Yeah. Alcohol involved?
He lives
maybe?
in San Francisco and it's a very narrow and tall, you know, those buildings. Yeah. Fell down the stairs. So. Although this looks a mess, right? I'm not going to put one of these on yours here. But this just goes to show, if you logically think through this, you have all the information to describe this very complex fracture. It's a right. The top left X-ray says R, right? It is right. Okay, what bone? Humerus. What part of the humerus? Humeral head, humeral neck. How do we describe it? Disaster. Comminuted. Okay. Yes, he fell down the stairs. I get a lot of calls in the middle of the night from drunk friends. Fell down the stairs. It was about 3 in the morning. He put himself to bed. Thank God, neurovascularly, he was fine. And then went to the emergency room in the morning. This was a long thing. I might have pictures. I have pictures somewhere of him, probably in one of these lectures for you. The whole process. So at first they put him in a sling, then they were going to see if it healed, then they were going to do surgery, then they decided not to. This was a long road and everybody, remember how that near classification is like it's complicated quickly? He falls into it's complicated quickly. And so they really couldn't agree, like, do you do surgery? Does he not? Where does he fall? Blah, blah, blah. Let's see what he does. He's a young guy. Anyway, it's pretty fun. Pretty much, he can use his arm. He is right-handed, so thankfully, not a big deal. Okay.
Would this be considered dislocated or just messed up?
This is not a full dislocation. And remember, dislocations are kind of hard to see. If you look at the pictures on the top, you really can't tell where is the ball in relation to the socket. But if you look at the inferior pictures, and I'll, ooh, this was working. I hope so. Aha! Ball socket, not dislocated. See here? Not a true dislocation, but it's so comminuted from the fracture that up here it certainly looks like it. Yeah, okay, same thing on the bottom right. So did you guys see that? Good question. Oh, we were doing so well. Oh, well. Here, ball socket, it's not a dislocation. Here's the problem. So it's not a true dislocation, although up there you can't really tell. So that's where getting several views can give you that information, asking mechanism of injury, doing a good exam. Yes.
Do you get like MRIs on these people too? Because like all their sits muscles are probably torn, or there could be
Question. Yeah,
tears.
you can't really tell. Can you try the drop arm test for me? Not like this, right?
Yeah.
That's a good question. I'm trying to remember if he ended up having an MRI. I think he did at some point. The trickiest thing with, this is like trauma. This is really more ER medicine, but for trauma like this, in order to get good information from an MRI, you do have to be able to have the patient in a very specific position. So if he's kind of slinging stuff like this and you put him through the scanner, you might not get the same views that you want. You know, when you get an MRI for the shoulder, you usually go through, one arm down. They also put you through with your arm up above your head, which to get all of the information of that 3D structure, which this patient can't do. So that's like a tip of the iceberg issue. They'd probably fix the fracture first. And if there was a secondary issue, go back and fix that arthroscopically.
Okay.
Yeah. Okay. I'll recognize up front. This is not something I'd ever ask you in this format on an exam, but I want to see where we go. 47-year-old male comes in for evaluation of his dominant right elbow, which has been bothering him with activity for the past 3 months, especially with activities requiring wrist extension. Whoop, that's a hint. He's an active squash player, that's a hint, and has been unable to continue his sport. Examination shows tenderness at the common extensor origin. What is the next best step? So first of all, what's the step? What's going on? Oh, which epicondyle? Lateral extension, yep. Do you need to know what's going on to really figure out the best treatment? No, you really don't. What is his next best step? On sugars. PT is not an option. Formal. Is it PRP? We talked about PRP. Ryder was the champion for PRP. Are you not going to give this guy PRP?
No, I'm not gonna
Oh.
give him PRP.
Why not?
Because I would give him a cortisone injection.
You give him a cortisone. What else? Yeah, and this is where it's tricky. These are all good treatments for this guy. But when you see questions like this on our exams on the boards, although many of you have clinical expertise in orthopedics, and you're probably going to do PRP or cortisone or something, he can't play, he's miserable. Right, when you see things like what is the next best step, look at what's been done, nothing, and start with the most conservative thing. So for him, that's going to be eccentric exercises. That's PT in disguise. You give him a piece of paper. Oh, try these at home. So yes, these are all, I mean, maybe not the surgical treatment off the bat, but generally speaking, these are all things that would be treatment for him, depending where he's at in his care. Yeah, clinically, I'd probably do something more aggressive for him because he's in a lot of pain. But in a test question like this, read what the actual question is asking Next best step, he's done nothing. It would be exercises. Another good first best step would be anti-inflammatories, things like that. So as you're reading, I know a lot of you are familiar with orthopedics, you've been patients, you've worked in the field. Try to think more kind of book medicine as you go through this. All right, because it's easy to get some of these very simple things wrong, because you know the right thing to do, but then you have to know what the book thinks the right things to do. Jalen.
What is squash?
Squash, kind of racquetball-esque. Yes, yeah, inside tennis with a smaller racket, faster ball. AKA it's tennis in disguise, lateral epitome. Thank you, Mel. Anybody play, do you play squash?
No, it's beautiful.
Ah, we know about racquetball. Okay,
Oh,
got this? So this is less about the question and more about just literally like reading and answering the question in orthopedics. Because a lot of times your brain's gonna go, when I had this, this is what I did, or in my practice, this is what we did. And while you're not wrong, if you answer a test question that way, it might be wrong. Okay? Gotta be full disclosure as we're going into kind of the exam part of how to look at these questions and take it. Okay? What else? Splints. Generally speaking, know what they're for. Kind of did those in the cases. Generally speaking, these are not new things. Also, I think through the library, if this is something you want now, I think you have everything you need in your slides in your current book. If you want to deep dive more into this, you have these resources through the library. If this is something in the future you want to look at. So that's all I have for upper extremity. Thoughts, questions? The thing I don't miss seeing is back pain. When I worked in spine, back pain is hard, it's complicated. It's a very, very common complaint. And it's a common cause of disability, even in what I would still consider young patients, right? But it is the second most common reason for seeing a provider in the US. So with that, you don't have to like orthopedics, but you're gonna see back pain. Just like most of orthopedics, you can use, mechanism of injury history and then some physical exam to kind of classify and find, is this something local or is this something that is referred? Generally speaking, we're not going to get too far into this, but we see a lot of write-ups. The collection of muscles with an innervation from a single nerve root, that's a myotome. And the century distribution of that root is the dermatome. So you're testing different dermatomes, things like that. That's where those names come from. We start talking about back pain. So lumbosacral or SI, they're not the same, right? Lumbosacral is where the lumbar spine meets the sacrum. The SI joint is all part of the sacrum, the sacroiliac, but they're generally grouped together because anatomically they're so close. It's hard to differentiate them. All right. If this gets inflamed, we call this kind of a sacroiliitis. It's a very, very difficult to prove that. We talk about the joint space of the SI joint. It's like a millimeter. I don't know. It's not like the joint space in the knee when you can see on an x-ray, oh, it should be this much and it's this much, right? If you look at an SI joint with and without kind of sacroiliitis, it just looks the same. It's a really, really tiny joint. It always has a very, very tiny space. So we kind of throw this out there as a collective term. Sometimes it's when we can't really figure out anything else. We just say like, oh yeah, we're basically saying this area of your body is inflamed. So kind of a carpet, we'll just throw it all over everything. So it's not the same as radiculopathy. Again, I said, think of that more as a symptom. Like you can use this as a diagnosis, but it's pretty non-specific. Okay. People that get kind of this generalized lumbosacral pain, SI joint pain. Sometimes it's from trauma, pregnancy, just from mechanical difference of carrying a fetus and, front kind of weight, repetitive sports, stress, previous injury. But the reason this area is so commonly irritated and it's easy to get irritated, is this is the part of the body where the stress transfers from the upper body into the lower body. So it's that transition point. So it's not like if we cut you at half, we kind of section you off here, but in a way, that's where all the stress from the upper body lands on the lower half. It goes through that lumbosacral, that SI joint. That's where you hit up, bless you. It distributes through the pelvis and down through the lower extremities. So that's why this area is so commonly irritated. This is kind of a clinical diagnosis. I can't use x-rays and tell you, oh, you have sacroiliitis. Or if you get MRIs and other imaging, it's not really going to come back saying sacroiliitis. It's this broad term. All right, this can be secondary from something else, but this is a broad term, it's kind of big, right? Now the SI joints, if you're doing an exam, you might remember if you look for the little dimples in the back, that's kind of where the SI joint is, where the sacrum and the ilia come together. Spinal stenosis, we hinted at this. I know you guys have somewhat of a background on this, but we hinted at this on Tuesday. This is something that happens chronically. It's usually from osteoarthritis or degenerative changes. You'll see on a lot of MRI reports, chronic degenerative change. All right, so what's happening within the spinal canal is there should be a big opening, a big wide open canal for the spinal cord to go through. And as the bones grow osteophytes, as a kind of finding of osteoarthritis, wear and tear arthritis of the spine, those osteophytes, those bone spurs, kind of constrict and they grow into the canal and they narrow down the passageway. And that is what causes spinal stenosis. It's a narrowing of the spinal canal, usually from a very physical, mechanical cause like bone spurs. All right, these patients will tell you, look, my back pain is really bad when I extend. It's much better if I flex and lean forward. So for that, people say the shopping cart sign. You know, they'll go in, but you'll see them not only get the shopping cart, but they'll be leaning over it. And they'll tell you they can walk further leaning over the shopping cart. So they can go, you know, they can't walk for exercise outside, but they can shop through the grocery store, mostly because they're leaning forward on this. The reason is when you extend, you end up compressing the spinal canal a little bit more naturally. And when you forward flex, you kind of open and relieve that space a little bit more. So you're helping them with they're helping themselves with that neurogenic claudication. All right, to find this, usually you need to get an MRI to truly look at how big that spinal canal is. There's no great way to look at that with x-rays. You know, the way you can use this as a clinical diagnosis with x-rays is to know that there's a lot of degenerative changes, a lot of bone spurs, a lot of arthritis within the spine. But true stenosis is diagnosed with an MRI. All right, you'll see a lot of these patients usually end up with a secondary kyphosis because they feel better in a forward flex position. They kind of naturally adopt that over time. They'll end up with a muscle kind of imbalance or weakness of their lumbar extenders. So even if they want to stand up straight, it becomes a chronic problem where they really can't. So we treat this conservatively as much as possible. The usual stuff, right? Anti-inflammatories, physical therapy, even some steroid injections. But if this gets pretty severe, and this is a common reason patients have spine surgery, is they'll have a spinal decompression. So you'll go in and literally take off those extra bone spurs, open up the space of the spinal canal. Similar idea of what we do in the shoulder for impingement. This is a spinal cord impingement. That's the same thing in the shoulder. That's SAD, subacromial decompression. You open the space in the shoulder. Same thing in the spinal canal. Now, this is usually done with a secondary, as a secondary part of a procedure, like a laminectomy or like a fusion, because those are the things we do to treat the arthritis, and we'll secondarily kind of get rid of all those bone spurs and open the canal at the same time. We think about herniated disc. This is kind of disc bulging, disc herniation, disc rupture. Those are technically three separate things, but they all involve the disc, so they're here. A lot of the symptoms are going to be the same. That's why they're here on one slide. So first, the disc can bulge, then it can truly herniate. It can also rupture. Because of there's kind of three different things, this can be acute or chronic. It can be as simple as, yeah, moving the couch, 1, 2, 3, lift, you've got a disc rupture, herniation. Or this can be kind of a chronic thing over time. That's usually with a degenerative process. All right. This is usually secondary to some other spinal issues like osteoarthritis, or like some of the other things we're going to talk about, the S words, usually in combination with the S word. But the most common level of a disc being irritated, herniated, ruptured is at L4-5. So that's the disc between the 4th and 5th lumbar vertebrae, or the disc between the 5th lumbar vertebrae, L5 and S1, first sacrum. So those are the two areas you're going to see. Know which nerve root comes out from where. And they'll give you maybe localized pain kind of in that lumbar sacral area, and probably radicular symptoms. So if you look in the bottom left, and you see the disc kind of bulging or going outside of where it should be, it's going to press on something else that's in the area. That's usually a nerve. So depending on what nerve it's pressing on, they're going to get symptoms in that nerve root, which is typically pain, burning, numbness, tingling, kind of like that cervical radiculopathy. They're going to get leg radiculopathy, right? We'll talk about special tests. These people probably have a positive straight leg raise, maybe a positive cross straight leg raise. And again, you can't see this soft tissue. This is a soft tissue issue. You have to get an MRI. You have a strong clinical suspicion, but get the MRI to confirm. And like everyone, we'll do a good neurologic, neurovascular exam. If there's no neurologic deficits, you can treat this conservatively. That's probably 85 to 90% of patients. Same conservative treatment we give everybody else. PT, NSAIDs, muscle relaxers, steroids, heat, rest, maybe some epidural injections. Only late do we go to surgical decompression. Most of these can be treated non-operatively. All right, so we think about kind of these disc problems. Very common to think of the jelly donut analysis. So jelly donuts are just like spinal discs. You know, the outside, the bread part, is the annulus fibrosus, and then the inside, or the jelly, is the nucleus pulposus. So all of your spinal discs are between the bones, right? All your jelly donuts are in there. And the reason that we can have kind of bulging discs, herniated discs, ruptured discs, it's different. That's why the symptoms can change. So you see your normal disc. A bulging disc is kind of if you put a little bit of pressure and that jelly is almost about to kind of break out of the side. So it looks like more of a sandwich where you can see the jelly as opposed to being contained within the bread. You know, a herniated disc is truly when there's so much pressure on the donut that just one slit is open and all the jelly started pushing out in that one area. All right, a ruptured disc is basically if you pancake smashed the disc. And then a degenerative disc, that's like if you let your donut sit out for, you know, a couple days, a couple weeks, the bread gets kind of stale. It's not really going to be that great anymore. And maybe it starts to look a little different. So there's degenerative and different changes to that. So truly a herniated disc, a ruptured disc, that's when the jelly is coming out. That's when you're going to get the neurologic symptoms because that jelly is pushing on what are the nerves in the area. So lumbar radiculopathy is going to be like cervical radiculopathy. It's not a true diagnosis. It's more of a symptom. So your diagnoses are going to be here, you know. You have a disc bulge, a disc herniation, a disc rupture. So we call, you know, HNP, herniated nucleus pulposus, Now you know where that comes from. A herniated disc, medical term, HNP. The jelly is herniated, it's come out, it's come through the outer part of the bread. All right, so herniated disc, HNP, that's where we get that meaning system. Those patients will have symptoms and signs of lumbar radiculopathy, but it's because of the original problem up in the lumbar spine. So it's either inflammation of or compression of a nerve root in the lumbar spine that refers down, the leg and in the pattern that correlates to the nerve that's being irritated. So again, pinched nerve, if you will. Pinched nerve in the neck, pinched nerve in the back, same idea. Sometimes people come in, oh my gosh, I have the worst pain. How did this happen? Well, yesterday morning, I just bent down to tie my shoe. Boom. What they probably had is a degenerative jelly donut that just the wrong mechanism was enough to finally tear the bread and let all the jelly out. So it's not that they bent so vigorously to tie their shoe. It's just kind of that was the last straw for some reason. So that's why these things usually go hand in hand with degeneration. Not always, but they usually do. Now, you can imagine if the jelly comes out of the donut, it's sitting on the nerve root, someone comes in, they do all the conservative therapy, they feel a lot better. We've gotten rid of the inflammation. Have we done anything surgically to move the jelly? No. Maybe the jelly kind of dries up and it's not so close or not as irritating to the nerve, but those patients with a known herniated disc get these flares because the jelly's still there. When you're working someone up for radiculopathy, just like in the neck and the arm, you have to say, is this a motor thing or a sensory thing? Numbness, tingling, pain versus weakness. You have to know that because that's going to affect your pain. So a lot of times, this will be very severe pain. Patients will have burning, sharp pain. They won't even want to sit on the exam table for you. They're really struggling to move. They're in awful, awful pain. They'll get muscle weakness, muscle spasms. And if they increase their intra-abdominal pressure or stretch the nerve root, it's going to send things through the roof. So coughing, sneezing, anything to increase the intra-abdominal pressure and increase that pressure on the nerve will send them overboard. And one of the special tests is called a positive straight leg raise. So have your patient, usually we do this laying down, patient's laying flat supine, and you'll possibly, if they have radiculopathy in the right leg, you'll take that and just say, okay, kind of relax, let me your leg, and just slowly flex up at the hip. So it's a long straight leg, just flexing up. And if it reproduces that pain, their radicular symptoms or pain, that's positive. You have to make it to at least 35 degrees of motion. But, from 30 to 70 degrees, if it reproduces, that's a positive test. And what you're doing is you're stretching the nerve root. And so if you stretch that nerve root more and they get their symptoms, yeah, they're pretty uncomfortable, which is another reason they don't want to sit, because sitting will stretch the nerve root in the back of their leg. If you lift their leg and say, oh, my hamstrings are so tight, negative test. All right, this is again where you can test with the other side, what's their normal mobility. But there's also this cross straight leg raise. When you do it to the other side and it reproduces the symptoms in the original leg, so the other leg. All right, when you work this up, patients with symptoms of lumbar radiculopathy, you're probably going to have a normal x-ray, but the MRI will show the nerve compression. If it's something like a weakness, you might send them for EMG. Most of the time, this can be treated conservatively. If it's severe, you can do an epidural steroid injection, or yes, again, go in and do surgery. Now, these patients will come in, they'll have 24 hours of pain that's severe. They'll be begging, they'll say, whatever, take me to the OR, do whatever you have to do. They'll be desperate for relief. So, their symptoms can take days, weeks, until it's really all the way better. Some patients in really severe pain, we usually give them anti-inflammatory, steroids, muscle relaxer, heat therapy. We try to do everything at once because they are absolutely miserable. The other way you can sometimes tell when patients have really severe radiculopathy When we think about the straight leg raise or the positive straight leg raise, they'll walk into your office like this. If it's their right leg, they'll walk in like this. And it's not because they can't walk normally, it's because if they lift like a straight leg raise, if they take this leg so far in front, it will stretch the nerve root even more. So they have what we call a bridle walk. Step together when you go down the aisle. That's how they'll be walking into your office, very gingerly, and they won't really want to move that leg too much, because if they stretch it just too far, they'll get that burning, zinging electrical pain all the way down their leg usually. We talk about sciatica. This is literally radiculopathy affecting the sciatic nerve. So not all radiculopathy is sciatica. Patients definitely think it is, but it's not. So when they say, oh, I have sciatica, they really just mean they have radiculopathy. Is it the sciatic nerve involved? Maybe, maybe not. But that's what they're going to come in and tell you, right? So this is the inflammation of the sciatic nerve. Usually it's from the same thing, HNP, herniated nucleus pulposus, bulging disc. It can be from, again, more chronic stuff, spinal stenosis, arthritis. These go all hand in hand. They'll have the same symptoms as everybody else with radiculopathy, but it will be in the sciatic nerve distribution, which you see there in the pictures down the back of the leg. So the sciatic nerve is between L5 and S1 vertebrae, one of the most common places that we see this. Again, they're going to have that same severe symptom. They're going to be doing that bridle walk into your office. Clinical diagnosis, and get the MRI for confirmation. Treat it conservatively, same treatment. All right, but not all radiculopathy is sciatica. Here's your straight leg test. So usually we do this when the patient is supine. You can see in the picture from the top, you can do this in a patient who's sitting up. Especially older patients, they get vertigo, they can't lay down, a bunch of stuff. You can do it in sitting up. You do have to have them relax, and so you can stretch their leg right out. And in patients with really severe radiculopathy, you can't get their leg even all the way straight. They'll start screaming. If you dorsiflex the foot, again, thinking of the distribution of a lot of the nerves that are commonly affected, you're doing a nerve stretch from the most inferior portion of that nerve as well. So in most patients, you should be able to flex the hip to at least 80 degrees. That's why for a straight leg raise, you know, the symptoms will be reproducible at somewhere between, what, 35 and 70. You'll be able to get them up within normal range of motion. And again, the test is only positive if it's giving them those symptoms, not kind of a hamstring tightness. Here's a refresher on nerve roots. You can imagine, depending what is affected, if it's motor and or sensory, you want to check reflexes in these patients. They've lost their reflex. We're really concerned. Is there so much pressure that we need to decompress it surgically quickly or jump right to epidural steroid and see how they respond? Because that weakness can be permanent. Membrane foundations, heel walk, toe walk, lift the big toe, press against my hand. These are some of the things that you'll incorporate as you're doing a neurovascular exam in conjunction with this orthopedic component. It's also a reason why in the spine, you can have orthopedic surgeons operating on this. You also have neurosurgeons operating on the same problems. They kind of have a lot of crossover there. Also like duel each other to the death on who's better. So. All right, here's some S words. Gotta know these. Spondylosis. It's basically spine arthritis, but it's kind of a broader term. But it's that chronic wear specifically to the spine. So it's cartilage and bony wear. You'll also hear people kind of cross over this term with degenerative disc disease. That means the jelly donuts have been sitting out for a long time. degenerative discs, old jelly donuts. But this basically means kind of spine arthritis. But it's, arthritis is just the joint and articular cartilage. This is a little more broad. So we're talking about the discs as well. Degenerative bone, cartilage, discs. Degenerative spine is spondylosis. Now how are we going to say it? Spondylolysis, spondylolysis. That is a stress fracture. There's the pars into articularis of the vertebrae. It's very common to see this in the lumbar spine. It's going to be from overuse. We're going to break these down again. But these are just to compare one to the other. And then spondylolisthesis. That sounds slippery. So that's the slipping of one vertebrae on another. You can slip forward. It can also slip backwards. Retro spondylolisthesis. All right, a lot of these things go hand in hand. You can have all three of these. Not two of three. You can just have one. But for spondylolysis, the LOL is my little brain nugget, right? The LOL, it's not really funny to break your mother's back. We were on the sidewalk, some of you. Yeah. So LOL, it's not actually funny to break your mother's back. This is from chronic back bending or arching activities. You know who gets a lot of this? Gymnasts, yeah. A lot of gymnasts. So when you see young, this are not all kids, but when you see young athletes, young people with this, it's usually from a diver, a gymnast, activities like that. So that overuse. And just mechanically, those vertebrae and the pars are touching, pressure. And at some point, whoop, one just kind of gives and it cracks. Usually asymptomatic. They might feel like they strain a muscle, they're going to pull a muscle, whatever. Kind of diffuse symptoms. If you get an X-ray, which I have on the next slide, it's very, very obvious. You get the Scotty Don sign. Usually you can treat it conservatively. If it's bad, you can brace it. For gymnasts, if it's bothering them, you either brace them or tell them to hold off on, certain parts of their sport for a number of weeks to let this calm down. This is not something we really go in and surgically fix. But it does make people more prone to later having the vertebrae slip. Because the spine should be stacked in certain alignment, certain angles, and we start messing with that. When we think about the top half of the body distributing to the lower half, weight and pressure. When you mess with this, it can be more likely that everything else in the ladder can be affected. So here's your Scotty dog sign. Very cute. This is better than the gamekeeper's thumb, right? This is very cute. You look at x-rays, especially some of these oblique x-rays, see if you can see the outline of the Scotty dog on the top right. You can kind of see the overlay there. And if you look at this pars defect, right, you want to make sure none of your Scotty dogs are wearing collars. If your Scotty dog is wearing the collar, there's a fracture through the pars. This is another thing that I have. I did this marathon training. I think I was just very, very tired and I was running downhill, just flopping downhill instead of running appropriately with your core in downhill. And I think just some chronic pressure and everything just bloop. I didn't know until later that night. Then I had very acute symptoms. That was one. We took my x-ray when I got into the office on Monday. My Scotty dog had a collar. Okay, whatever. Calmed down, a couple NSAIDs, not a big deal. And then a couple of years later, I don't even remember what I was doing, but the other side went. So once you can have a unilateral, just one side of the vertebrae go, but if you have one side, it's probably more likely because of stress and strain, the other side will go at some point. You do anything? Not really. Now, people can congenitally have this. So sometimes it's tricky because you'll see this and you'll ask them, oh my gosh, are you sure? Do you do this? Yeah, do you have back pain? No. Maybe it's congenital and it's always been that way. But again, sometimes this happens and it's asymptomatic. Does it matter? Not really. So if you find this and someone is very asymptomatic, or maybe it's congenital, probably good to tell them, by the way, you ever get your back x-rayed for any reason? People are gonna tell you you broke your back here. It's already here. This is normal for you. Don't panic. Good to let them know that they're in a car accident, they end up in the ER, whatever, they're x-raying their back. Oh my God, you broke your back. Things like that. Let them know when you find stuff like this. And then here's your spondylolisthesis. So this is more chronic. Again, it's usually associated with the other two things. This can be from overuse or again, that chronic spinal hyperextension. When you think of the anatomy of back bend, you're putting so much stress. It's usually not something people will know is happening or care that it's happening until there's enough slippage that the nerve root is affected. So then they're going to get radiculopathy symptoms, right? Those neurologic symptoms. You take an x-ray, you'll be able to see this because again, we're looking at bone slipping on bone. You can grade it 1 to 4. Usually it's conservative. Only in late cases do we go and surgically fix this. But usually it's with a lot of other things going on. We talk about fracture. There is the traumatic fracture, the lytic lesion fracture, cancer, stuff like that, infection from osteomyelitis. But the biggest thing to remember is, I think what we said on Tuesday, right? Osteoporosis. Osteoporosis leads to a lot of compression fractures. They're typically atraumatic. People will sometimes have symptoms, sometimes not. They'll know they have it, they don't. What they'll start to see is in that middle picture, right? Kind of the hunch, the kyphosis, the leaning. So the bony anatomy is changing. So you can get a wedge fracture, and it's exactly that. And you get a wedge picture where the vertebrae collapses on one side more than the other, and it affects with how people stand, like you see in the middle. You can also get a burst fracture. That's more emergency medicine, falling from a tall height, landing on your heels, transferring the pressure through the vertebrae, and that's truly the vertebrae kind of just like explodes. All right, that's a high energy, that's an axial force. But for most of these osteoporotic fractures, they'll say, oh, I used to be 5'4", now I'm 5'1". That's a hint this is happening. They'll get that kyphosis. You can see this on x-ray. You want to look specifically, CT is very good for looking at occult bony things. Sometimes you can brace these patients, but again, it's a lot of physical therapy and conservative treatment. It doesn't typically bother them until the nerves are affected, right? It's changing and there's neuropathic pain, radicular pain. You do this for tebroplasty where you put cement basically into the fracture site to kind of pump it back up and hold it open. There's not enough bony scaffolding there to hold it up. Or you could do a kyphoplasty, you kind of put a balloon in, open the space, and then put cement in there. We hear those. And a lot of these vertebral fractures are also in the thoracic spine. A lot of what we talked about was lumbar spine, but you get the kyphosis. If you see in the middle picture, you can imagine those wedge fractures are all in the thoracic vertebrae, causing the true pump, if you will. Now, coccyx fractures, here we go. Fall down the stairs, that's another one. You break your tailbone. It's a very common thing that happens in osteoporotic patients. They'll basically tell you their butt hurts, right? So they'll have coccyx pain. If you can feel it, it's tender. They won't be able to sit. Sometimes you can visibly see it. You can typically find this with an x-ray, and it's just a lot of conservative care. This is a non-surgical thing for patients, but it's exquisitely painful. All right, so within this, I know there's a bunch of hidden slides. Like I said the other day, those are kind of reference. Use those for EM if you want. I'm not going to test you on anything on the hidden slides. So while we're enjoying the world of MSK, and I would argue maybe it's simplicity, we do have to sometimes think outside of the box because low back pain, very common, second most common thing that you're going to hear, but it could be simple. One of these things, maybe all three spinal things at once, but it could be multifactorial as well. So it could be just a bunch of ortho things that can pile on each other, or back pain can be any of these, right? A AAA, it could be from gastric stuff, peptic ulcer disease, kidney stones, pancreatitis. PID, endometriosis. So we do have to think outside of the MSK box a decent amount, maybe more than I'd like, specifically as we get into a lot of the hip stuff. So for the hips, more bursitis. We talked about broad bursitis and some specific bursitis symptoms already. This is bursitis in the greater trochanteric bursa. It's located over the greater trochanter, which is labeled there, the outside, the big bump of the bone. Right, trochanters are usually where there's origin or insertion of muscles. Usually a lot of insertion sites, just like the humeral head, all of those sits muscles, right? 3 on the greater tubercle, 1 on the lesser. Same thing here. There's a lot of big, broad hip muscles that insert right around the greater trochanter. So when you get bursitis here, it can be from chronic stuff, runners. It can be because there's tight glutes. The IT band is something I'll talk about next. But just like any bursitis, if you push on it, it will hurt. People say, oh, I can't lay on that side at night. I'm a side sleeper. I can't lay on my left side. It kills my right hip because you're compressing that inflamed area. That's what they'll tell you. You know, they'll tell you it's kind of sore, it's achy, it feels bruised. Pretty clinical diagnosis. It's really tempting when a patient comes in, they'll say 2 things like, well, you know, I was training for this half marathon and it was going fine, but over the past couple days, the side of my hip is hurting so bad and I can't sleep on that side. Tend to be like, just stop there. I've got you pegged. We'll save a lot of time if I can just tell you what's going on. So like just a couple sentences of history, you really can figure out what's happening. Now, by due diligence, you want to make sure there's not a secondary thing going on and you listen to them talk and all of that. But during the exam, you just go, bloop, and then they're like, ah, and you're like, yep, I was right. They think you're a genius when you can figure this out. Oh, that's it. You found it. Oh, like, yep, dust your shoulders off, another day in the life. But we treat this conservatively. NSAIDs, PT, you're getting the theme. A lot of this is treated the same way. The thing I will say for this bursitis is if people have bursitis and I do a cortisone injection, it goes into the inflamed bursa. We don't put stuff into tendons. We do put stuff into the bursa itself. So it doesn't feel great, but it's effective. So that's something, you know, some injections hurt a lot, some hurt a little, some don't hurt at all. This is one that's pretty uncomfortable. You know, I mix steroid with a numbing medicine, which happens quickly, but not instantly. So you do have to put this medicine in the inflamed bursa. But then when, you know, 10 minutes lidocaine takes effect, they think you're worth $1 million and more. The downside is we have to figure out why the bursa is chronically inflamed. Because if we don't, it will come back. So it's highly associated with this kind of IT band syndrome, iliotibial. And we think of anatomy, ilium, tibia, you know where those things are. But it's this TFL, your tensionofasciolatum muscle, that originates up in the ilium. It inserts down on the tibia, side of the knee. So typically you'll kind of get this first plus a bursitis. But if you look, this is more kind of lateral, more external than the bursa. The bursa is protecting this from rubbing over the bone, the greater trochanter. The repetitive motion, again, runners, tight glutes, same kind of discussion. Patients with this will have usually inflammation of the whole IT band, which is the whole lateral hip, and sometimes down over the knee. Tenderness over the whole TFL, and then where it inserts over the lateral femoral condyle. And if this is really tight, people complain of kind of snapping or clicking, sometimes over their hips, sometimes over their knee, those bumps, right? The trochanter, the tubercle, those bumps in the bone, it can snap over that. So some people come in complaining of that lateral knee pain. You see that red area? That's the insertion. You got to look at the whole origin area. Clinical diagnosis, a lot of conservative treatment. If they have a secondary bursitis, treat that. Otherwise, got to stretch out, if you will, the IT band. So a lot of foam rolling, more conservative. What happens if you haven't figured out already? You just keep running, don't stretch before or after. You'll definitely have this. If you don't fix the problem, it will come back. I had a worst IT band syndrome. I had someone inject my knee on a Friday, ran a half marathon Sunday, and by Tuesday I was limping around the office again. Because I did not do a good job of stopping what was causing it and probably stretching and doing all that stuff. As soon as you feel better, all your commitment to doing your conservative therapy goes out the window, so. Anybody recognize that guy? Yeah, Dennis Pitta. What happened to Dennis Pitta? Dislocated his hip? A lot. Yeah, he was so good. Yeah. He had to retire from the NFL because of some chronic injuries that he has, mostly recurrent then hip dislocations. So most hip dislocations are posterior. Typically, you're not going to see this. Maybe a pro NFL player, but usually it's a motor vehicle incident. And the reason why is when you're sitting, you're in a high speed, kind of usually head-on collision. When your knees go into the dashboard, the power pushes the hip wall posterior to the pelvis. Now, usually it's not just a dislocation. It doesn't kind of pop out and around. It usually breaks through the pelvis. So you have a fractured dislocation, a big problem. But Dennis Pitta had this plague. And once his hip came out once, I think this ended up happening bilaterally to him. He had like 3 on one side, 2 on the other. I think he had like a capsular tightening surgery. He tried a lot of stuff. He's had a lot of hip surgery. He basically had to retire from the NFL just from this very freak thing about hip dislocation. When this happened, they'll have severe pain, same thing as a shoulder or other joints, right? Muscle spasms, they can't move. Check neurovascular status first. And it can be tough to figure out on an x-ray which way the hip is out. Mostly it's posterior. You can figure that out from the mechanism of injury. You really want to tell, you can get this cross-table lateral x-ray. You have the patient lie flat, if possible. And instead of looking in front or behind them, you kind of look at them from the side and try to see where the ball is. Most of the times you put this back in ASAP because of neurovascular status. And this is a common association with an acetabular fracture. I think there's pictures of that and hidden slides further in here we're not going to go into. If you're worried about a pelvic fracture, again, you can get a CT scan. Oh yeah, I wrote that down. 3 dislocations in 4 years. Retired from the NFL. With this, you can look, like if you see under signs and symptoms, it says shortened and internally rotated limb. If you go to see, here's a picture like that. Can't really tell if that's anterior or posterior. But in most patients, they'll be sitting in a hospital bed and you can tell, you know, kind of one leg just looks a lot shorter and it'll be stuck this way because their hip is stuck behind the pelvis. So you can tell just by looking at them, is it an anterior or posterior dislocation. All right, we talk about hip fracture. A lot of times these are, quote, your little old ladies, kind of the classic picture of osteoporosis. Sometimes they fall, sometimes it's trauma, sometimes it's seemingly nothing. So the big question for these osteoporotic fractures is, do they fall, then break their hip? Or do they turn, twist, and in an osteoporotic hip, does the hip fracture, which then makes them fall? Who knows? It's kind of a chicken or egg argument, right? But they'll have some element, usually of trauma, falling, that caused the hip fracture. They won't be able to get up, walk around. You can find this with an x-ray. These are fixed surgically. We label the fractures based on anatomically where they are. Transcervical, that's a femoral neck fracture. Intertrochanteric, between the 2 trochanters, greater and lesser. Subtrochanteric, underneath the trochanter. So you'll see a lot of hip fractures, probably in the ER. When they're asking you to describe these, start with left or right. Look at what bone, and then describe what part of the bone. All right, the downside is the femoral head acts a lot like the scaphoid with its blood supply. If you cut the supply off to the femoral head, there's no secondary or collateral circulation to get blood there. So hip fractures have a high complication risk of avascular necrosis. Even when you fix them. How do you fix them? That also, it's a little complicated. I don't care that you know how to fix them. But we love our classifications and naming them after usually old white dudes. So depending on whose classification and what type of fracture is supposed to tell you how to fix it. The point is to fix it. The downside is we put a lot of hardware in the hip, so you can see kind of how those go, where those might go. And that doesn't really help restore blood supply all the time. So even if you fix this, there's still a high risk for avascular necrosis, which is why when a lot of people break their hips, instead of just kind of fixing it like we normally think other bones, we just replace the joint. So we'll act as if they're going to have avascular necrosis anyway. It does help that a lot of older patients who fall and break their hips already have some element of osteoarthritis. So we take everything at once and just replace them. We use these fancy tables at the bottom. You can see what it looks like at the top. We're all draped in for surgery. Fixing a hip fracture. Pretty easy in these patients to just replace their hips, sometimes easier than fixing it with true open reduction internal fixation. All right, we look at AVN, there's kind of your collateral blood supply. So you can see if you disrupt that femoral neck or below, probably going to end up with avascular necrosis because no good blood supply. Usually it's from, they fractured it, they've had an open reduction internal fixation, truly a pit pinning or something like that. Now, patients who have sickle cell disease, they're more likely for having this problem as well. Patients who have leukemia, lymphoma, specifically those who have undergone chemotherapy, they're at high risk for developing avascular necrosis. Same thing for patients who have history of chronic steroid use or chronic drug use or patients who abuse alcohol. The chronic steroid users, emphysema, COPD, asthma, right? Even your younger patients can end up with this. They kind of get this slow onset of hip pain, trouble climbing stairs, painful hip mobility. The earliest way to find avascular necrosis is on an MRI. You'll find it on an MRI before you'll see it on an X-ray. If you see it on an X-ray, it's pretty advanced. So this is where you have to use a good history and your clinical intuition. If you're highly suspicious for this, send them for an MRI, even if they have normal X-rays. The MRI is the most sensitive test for finding avascular necrosis. Karen? Probably. So clinically speaking, your patient comes in with hip pain. Most orthopedics are going to take X-rays anyway. Like we take them right in our office. I'll see they're normal, then I'll send them for the MRI. So it's unusual that you jump right to an MRI. You probably want to make sure there's nothing on X-ray first. But yes, if you're in a situation, you don't have access, but you're really suspicious this is happening. Oh, you had your hip pinned, there's all this hardware, and you're on chronic steroids, and you used to abuse alcohol, but you're in remission. You probably have AVN. Yes. Let me order an MRI. No, they'll make you get an X-ray first anyway. Now, in late findings, you'll be able to see it on an X-ray. So in those patients, I don't need the MRI. So I can save that. But the most sensitive thing is truly an MRI. What you'll see on X-ray is this crescent sign. And so that's where the femoral head just kind of flattens out and starts to basically collapse. That dead bone kind of destructs into itself. That third picture on the right of the X-ray is that crescent sign. If you look, I'll show you with the mouse. Oh, worked for that. If you look very closely, see this dark line? That's your crescent sign. So if you look here, nice round ball socket, okay, not okay. So that's kind of a crescent sign. Now we used to treat this with bisphosphonates. We typically do this in younger patients, trying to regenerate some bone growth there. That's if you find it early, kind of stage 1 and 2. Not always that successful. Commonly, these patients will end up having surgery. We do something called a core decompression, usually in younger patients. Most of the time, these patients end up with hip replacement. Most of these patients are older anyway, so it's fine to do the hip replacement. Hip replacements can last a lifetime in most patients, so it's not a big deal. Now, AVN in a hip versus a scaphoid fracture. So keep this in mind. You have a hip fracture, find that on X-ray. Usually that's going to be a surgical fix. Pinning, hardware, that leads to AVN. Most sensitive way to find AVN in that patient or without any hardware is going to be MRI. When we talk about scaphoid fracture, we talk about, again, acute injury, fall. Look at the X-ray. Even if the X-ray is normal, but they have snuff box tenderness, what test do you get? A CT. So try to keep these straight. CT is looking for an occult fracture. In these patients, you're not worried about a fracture. You're looking for a crescent sign. You're looking at blood supply and bony collapse. So those are very easy to mix up. We're talking about AVN in both, but kind of it's a different clinical picture. Jay. You hit it with metal. You can. These are good questions. These are background info. Yes. When you do ephemeral pinning, and there's a ton of things that you can use, it is metal. So can you do an MRI with metal? With that metal, yes, you can. You do have to order a special type of MRI called a Mars MRI or metal suppression imaging. When the magnets go through and hit metal without this special kind of MRI, basically it'll look like a big starburst image or like a pow, right where you need to see. You can get a special metal suppression MRI so you can actually see the bone around it. Usually we have a high enough clinical suspicion or they're showing signs of collapse on X-ray. But yes, you can get an MRI in those patients. Their metal is okay. They're not going to stick to the roof or the ceiling of the MRI scanner. Same with hip replacements. Those patients can get MRIs. Usually we're getting Mars MRIs, special metal suppression imaging. Yeah, good job. Good with hips? Okay. Here we go. Oh. Let me give you the intro. I'm not going to go into like true diagnosis today. There's a lot. The anatomy of the knee. Also, speaking of TikTok, I heard something the other day. The 90s are back. Like Avril's back. Yeah. Go figure. Last year the class was like, I don't get it. You get it? Thanks.
So complicated.
Oh, I'm glad she's back then. Why? Yes. Why is the knee so complicated? All right. What do you think about this? It is a complex hinge joint. We talked about this a little bit in AMS, but it's a refresh. Hinge, right? Think of the door, open, close. The knee, up and down. But it's a complex hinge joint, so it's not just a basic hinge joint. So what that means is the knee does flex extend, but there is a rotational component. Not the same as supination, pronation, but there is a small, subtle rotational component as the knee is flexing, extending. The reason why is because you have a round bone, which is the distal femur, sitting on the top of the tibia, which is essentially a flat bone. We talk about shoulders, hips. Here we go. Looks like it belongs. When you look at knees, round bone, flat bone, it's kind of like square peg, round hole, right? Like this was not designed well. So for that reason, there's no kind of internal bony stability. Ball and socket, hip and pelvis, good innate bony stability. We seal it with a labrum. Great. Done. We look at the knee joint, not so much. So you are completely reliant upon ligaments, muscles, the menisci, and the capsule to support the round bone staying on the flat bone, especially through mobility, flexion, extension, and rotation. So with that, you've got ACL and PCL. What does that protect against the round bone doing on the flat bone? Sliding too far forward, sliding too far back. What about MCL, LCL? Yes, kind of tilting and falling off of one side or the other. And what do the menisci do? Menisci. What is that?
Shock absorption.
Yes, they're shock absorbers. That protects against cartilage wear. That's good. Lower extremities take a lot more pressure, 5 times your body weight when you're jumping, running. What else do they do? What's that?
The friction.
They do help friction, yes. It acts kind of like a labrum in a way, and that kind of conforms the round bone to the flat bone. If you look at a labrum, it's kind of the same thickness the whole way around. When you look at the menisci, we say they're semi-lunar, moon-shaped, crescent-shaped, very fancy. But on the outside, on the peripheral edges, which is all the way medial, all the way lateral, they're really thick. And when you get to the kind of more medial, internal, middle of the knee, they go from thick on the outside, like a really tall wall, down to thin. So that kind of creates the conformity of the round bone to sit on a flat bone. Make some sense? Okay. We're talking about round bone, flat bone. What about the guy in front? What about the patella? I mean, he's a triangle. He doesn't fit anywhere that well either. So what keeps that in place? There's a couple things. Patellar tendon, that's inferior to the patella. Why doesn't it pull so far down? Why is it in the middle of the knee joint? Quad tendons on top, connecting to the quad muscle, right? So there's a lot of things. The capsule also helps keep the kneecap kind of in line. But because of that, the knee is very, very complicated to diagnose and deal with. That's why a lot of times you'll get more than one issue going on. You have just an isolated lateral meniscus tear, you have isolated ACL tear, or do you have both? So I will leave you with that this morning as far as wrapping your mind around the knee and Avril and why they are such good friends. Some of you have taken your rheumatology quiz. Well done. Grades look very, very good so far. Thank you for your hard work in studying. I know yesterday was a big day. Thoughts about anything today before I let you go?